need to do some housekeeping first. There is no fire alarm planned, so should the alarm sound, you will need to leave the room, obviously, following the fire exit markers to the evacuation point. Toilets are outside this meeting room to the left, and please note this meeting is being recorded, and a copy of the recording will be available on our website for those who wish to view it. Can I also say, just in terms of some further practical points as to the running of the meeting, again, just to ask those presenting reports to the board this morning, the colleagues will have read the reports, and if I can ask colleagues to draw attention to anything that has changed since the paper was drafted. We will look to take a short break at around 10:10 this morning, and then again at 11 o'clock. Can I, in the first instance, because this meeting is a meeting of several parts, welcome the following colleagues who are joining us this morning. Firstly, Sally Davis, our Deputy Medical Director, who's attending on behalf of Dom Herford, our Exec Medical Director, who has given his apologies. Dr. David Miller, and who was joined by Dr. Stefan Reid from the Taff Vale practice. David and Stefan are here in respect of item 3.1. Can I also offer a very warm welcome to Councillor Amanda Ellis. Amanda is the Plaid Cymru County Borough Councillor for Ynys Wall, and Amanda is here also to take part in the discussion around item 3.1. We were hoping to be joined by Councillor Howell Grono, but unfortunately Howell is unwell today. So I understand that Councillor Ellis will be speaking on both. I think you've got two speeches that you've been able to merge into one. But a great pleasure to welcome you this morning to our board meeting. Can I also welcome colleagues from Plaid Cymru, Kerry and Elizabeth, who are joining us. Very good to see you again this morning. Linda Thomas and Sally May are both joining via Teams. Good morning, both. Good to see you this morning. And apologies, we have received apologies from Patsy Roseblade, Nicola Milligan, Dom Herford, as I said, and Howell Daniel. Item 1.3, declarations of interest. I've not been notified of anything that has been declared. Do colleagues have anything that they wish to raise now in respect of any item on the agenda? No? Okay, terrific. Item 2, the consent agenda business. Just want to bring in Linda at this point, just in respect of one item on the consent agenda, which is listed at 10.2.5 in respect of the NHS Emergency Planning Annual Report. There is a change in that. Linda?
Yes, thank you, Chair. So just apologies, we should have been clearer that the Major Incident Critical Business Continuity Procedural Guide is an appendix to the annual report, that and it's there because that guide has to go off with the report to Welsh Government. It also adds 111 pages to the pack. But of course, those of you that have looked at it recognise that it is our live Major Incident Critical Business Continuity Guide, but it's subject to a massive review because it's valid from October 22 to October 25. But because we've got the change to our operating structure, we're right in the middle of reviewing that now. So since we went to the care group structure from ILGs, we have got some additional operational guidance that tides us over while we do the full big review of that policy guide. We've hoped to get it ready for this meeting actually, but the number of people that you have to have involved to make sure that everything is lined up has meant that we're aiming now for October. So I think, again, the reason that this paper is here, and it's been through PPF, is that we have to send an annual report to Welsh Government on our business continuity emergency planning. The report's correctly here, and it's important that you see what's in there. The other two documents really should have just been an appendix and not really for full consideration.
Thank you, Linda. That's very, very helpful. Thanks. Okay, can I just ask colleagues, in respect of those items that are listed under the consent agenda, Does anybody wish for any of those items to be moved to the main agenda for discussion? No? Okay, well, I'll come back to that later this morning. Okay, we'll move to item 3 on the agenda. Item 3.1 is the primary care update, and it is in respect of the proposed branch closures at the Taff Vale practice. In the first instance, I'm going to hand over to get in as Chief Operating Officer to introduce the item before I then move to comments and contributions from Amanda, Stefan, and obviously David. But thank you.
Thank you, Chair. So good morning, everybody. This agenda item is to consider the recommendation from the contract variation group that is supporting the proposal to close the 2 branch surgeries of Taff Vale practice, one at Unisable and one in Kilbunny. Just wanted, before we go through the detail of the paper and the presentations, I just wanted to remind the board really about why this is coming to us. So this isn't a decision that has been taken by the health board. This is a proposal that has been made by Taff Vale practice. That has gone through due consideration, and David will take us through more of the detail of that in his presentation. But what we as the health board are considering is that recommendation as the commissioner of primary care services. So this is for us to understand and to seek assurance that the recommendation from the contract variation group has been appropriately scrutinised, and that we have appropriate assurance that any mitigations that are required to continue to provide access for the population of the affected areas is in place. And for us to also consider how we provide ongoing assurance that the patients in Unisable and Kilbunny, we continue to monitor that to provide assurance that those members of the population and the practice list of Taff Vale continue to be able to access timely primary care. I don't intend to say very much more apart from to first of all invite Dr. Stefan Reid to present the position from the Taff Vale practice around the challenges that have led to them submitting this paper, and then we will hand over to Councillor Amanda Ellis, who will present the position for the local population. I'll then invite David to take us through the paper and to provide the update then to board for consideration of the recommendation. So I can hand over to you.
Thank you. I would first like to thank you for the opportunity to address you this morning and present to you in person why we've come to the very difficult decision that we believe that the branches at Unisable and Kilbunny need to be closed. I'd like to introduce myself. My name is Stefan Reid. I'm a doctor and a partner at Taff Vale practice. We as a practice have roughly 17,000 patients with an area covering about 35 square miles. We are 11 doctors, 2 nurses, 3 HCAs, a pharmacist, a farm prac, and a roughly 20 admin and reception staff. Now, I joined the practice about 5 years ago as a partner and was previously there during my training years as a registrar about 8 years ago. Despite luckily other opportunities, I chose to return to Taff Vale, and that's not only because of the working environment, but because of the community that I feel really strongly about. Over recent years, there has been a considerable change to the provision of healthcare, as well as how patients are accessing services. With increased urgent demand, i.e. the want to be seen on the day as opposed to routine, the difficulty in keeping staff. Over the last 3 financial years, we've lost 37 members of staff, and some concerns over isolated working. We've had to come to the decision that was to effectively ensure the future of the practice. These discussions went on for months, and as some of us are from the area, we knew the implications of our decision, and that's why we deliberated for so long. It really wasn't an easy decision, and unfortunately, the solution was clear, but a difficult one to accept. The demand has increased significantly over the last 3 years. We've noted that patients do not want to see a doctor, they want to be seen on the day. We have always provided appointments for up to 6 weeks. These were often then not attended, as these patients were ringing again in advance, and these appointments were then just going to waste. We have 2 appointment systems. You have an acute and you have a routine. Now, your acutes are those ones who are unwell today, they want to see a doctor today, and the routine ones, it's fairly self-explanatory. These are the appointments which are booked in advance. Now, with regards to the acute ones, they've historically been dealt with an emergency doctor on the day who's always been based in Rhydfelyn, which is our main branch. And these patients then would be invited down to Rhydfelyn. So if you're unwell on the day, you will be spoken to by a doctor in Rhydfelyn and you will be brought down to Rhydfelyn. That's always been the case. So the closure of these branches is not affecting your acute unwell patient on the day. It's purely those routine appointments, which historically have been booked up to 6 weeks. So it gives that leeway of arranging transport, etc. The increased demand is the case for most practices, but most practices do not have 5 sites. The difficulty of having 5 sites is that at any given time, we need 5 receptionists, 5 doctors often working on their own. And during the latter stages of COVID, we were constantly cancelling clinics and moving patients around as we had constant sickness. And this was adding stress. It was significantly affecting morale amongst staff, as well as then the direct effect on the patients. Now, this is less of a problem now. The staff recruitment has become a major issue. There have been many reasons, but one that has been highlighted repeatedly is staff not feeling comfortable in working in isolated environments and often alone in buildings. As doctors, and I've been there so many times, myself and the reception staff, it's 5 o'clock in the winter in Unsibor, we have a home visit, we have to go out. And that staff members then left alone in a building in the winter months in the dark on their own. We have had to ensure that we support our staff, and that staff welfare is key for our future sustainability. Now, as mentioned previously, we've lost 30 staff members over the last 3 financial years. That's experience we've lost, that's familiarity with our system, and it's also the staff who train the new staff. So if you're having such a high turnover, that knowledge is not really being passed over. And to make matters worse, of those 37, 24 of them had only been in a job for less than a year. We are a training practice, so with both medical students and trainee doctors. So these must be supervised locally, i.e. within the building, and they cannot work on their own. Same is the case for our nursing staff and HCAs. So the primary care model for the future is a multidisciplinary approach, and that ideally should be under one roof where a patient can see a doctor, get a blood test or an ECG, see a mental health practitioner, see the pharmacist, and that requires everybody to be working together in the same environment. Our trainees, as well as nursing staff, have increased concerns regarding isolated working, and we know that comes with increased risk and generally poor service provision. For the future recruitment of staff, we realise that working closely together in a supervised as well as a supportive environment is crucial in both recruiting and maintaining staff levels, something that we have clearly struggled with over the years. I personally attended every partnership meeting when we've discussed this issue. I've also attended every patient engagement meeting. And we've taken on board a lot of the concerns of the local communities, concerns that we had recognised as part of our own internal process. We have improved access, where previously I mentioned that we had routine appointments up to 6 weeks. We've now reduced that to 2 weeks. We thought having the flexibility of 6 weeks notice to change working environments, arranging lifts was something that patients wanted. Seems that actually they want quicker access. So we've reduced that now to 2 weeks. And so far, the feedback from patients is positive. As well as improving access, we've increased appointments across all the 3 remaining sites and crucially increased what we can offer in Glencoe. So previously there would be a doctor there. Now we have a doctor, nurse appointments, as well as a HCA. You can do blood tests, ECG. And we also monitor our chronic disease, which is usually nurse-led in Glencoe. Whereas previously, all these were only done in Dewi Sant and Rhyfelin, which are our main big branches. We know that this will have an impact in both Kilfynydd and Ynysybol, but as I previously mentioned, we have made some changes to counteract this. For the future of Tap Vale practice and its population, I truly believe that closing these branches is the right decision. This is, however, with deep regret. Centralising our services, creating a safe working and training environment with a multidisciplinary approach is what's best for our patients. We have to look at the future and ensure that the entire population of Tap Vale have the best possible care, and this would be with 3 centralised services. I thank you again for listening and appreciate the difficult decision that you now have. Diolch.
Good morning, Body Dog Out. Thank you, Chair, for allowing me to speak this morning and to also represent my colleague, Councillor Howard Brown from Kilfynydd. And thank you to Dr. Reid. I appreciate it's a very difficult decision and I take on board what you said also. Unfortunately, Howard is quite unwell and very disappointed that he cannot be here in person today. With that in mind, we've penned a joint statement here as we have very similar concerns. Councillor Gron thanks you for allowing me to address the board on his behalf and the residents of Kilfynydd and Norton Bridge. So, Councillor Gron states, after speaking to residents, listening to their concerns at the consultation meeting, it is clear that we as the village do not support the proposal in front of us this morning. These concerns are also available to see in Annex 2. This also applies to Ynysybol. We also do not support closure of Ynysybol surgery. There are several reasons why, and I would like to mention a few today. Transport has been mentioned a lot during the consultation period and throughout the papers for today's meeting. Transport to and from Kilfynydd is not the best. Often we hear about a bus having turned up or the fact that it has been delayed by around 10 minutes. For those of us working and living in Pontypridd, it is safe to see why public transport will prevent patients attending their appointments or to be late. It takes 4 buses for a patient to attend their appointment, that's 2 there and 2 back, which will take around an hour and 30 minutes. Within the last week or so, a patient told me that they could not attend their appointment due to traffic and roadworks in the town centre. This is a prime example of why a local surgery is needed. One resident has raised with me how they would have to rely on public transport to get their child to an appointment. The bus is only accommodating 1 safe space for a buggy and would have to hope that nobody has got on the bus in a buggy or wheelchair before them. As stated, bus transport has been a huge concern for those who are reliant on an unreliable, costly way of getting to appointments. They are often late or do not turn up at all, causing patients to be late or not attend. If they use a wheelchair, they can only hope that no one else is on the bus before them with a buggy or a wheelchair, as the buses only have room for one of the above at any one time. That is a really concerning fact. Ynysybol patients need to catch 2 buses to attend appointments at Dewi Sant, Rhyfelin or Glencoe. I note that the report states that Glencoe is only 3 miles away from Ynysybol, but what it does not say is the surgery is at the top of a very steep hill. It's not on a bus route, and for those requiring to get to Glencoe with mobility issues by bus, would see them having to get off at the street above, come down the steep path to the surgery and vice versa to get home. The nearest stop going up the hill, nearest bus stop, is about 1,000 metres away from the surgery. It is a trek. I've heard people in the village saying they won't bother going to the doctors if they feel unwell, as it's just too much hassle. If I'm honest, there have been times that I felt the same, and I can drive myself. This is very concerning, as people may have a serious undiagnosed condition which may lead to serious consequences. Bearing this in mind, what is the Health Board doing to mitigate these difficulties with transport? There has been a mention of exploring community transport, but what does that look like? If someone is late to an appointment because of transport, will they be seen in a timely manner and not need to wait for an extended period? For some, this could impact on their employment. For instance, not getting paid whilst out of the workplace. Arranging childcare could come at an extra cost. How will Taffail practice deal with late attendees? Councillor Gronald states, parking at Derry Sant and Rydfelling is often a nightmare. I have experienced this myself and has been expressed by many patients. I have not heard how this issue is going to be resolved. There is not adequate parking at either site, and again, this will cause patients to be late or even miss their appointments. I concur with Councillor Gronald. Having to drive to Derry Sant, Rydfelling or Glencoe myself, it is extremely difficult to find parking at Derry Sant and Rydfelling. Has the Health Board considered speaking to RCT Council to maybe look at allocating staff car parking at Sardis Road, leaving Derry Sant car park free for those having to travel to the GPs? When will the vaccination centre close at Derry Sant? This too makes it even more difficult for people to park there. While the report mentioned that Taffail practice will take into account public transport when booking appointments, moving to 15-minute appointments and implement more telephone consultations, patients are concerned on how this will be delivered, as it is very difficult to get a telephone consultation at present. Ensuring an appropriate amount of home visiting capacity is available for frail and elderly and those vulnerable sick patients who need a home visit. A resident informed me this service has got worse over the last 12 months. Again, this is another concern in Annister Bull surgery. What does the criteria look like for home visits? How will this be implemented and how quickly? Councillor Gronald, there's also the negative impact the patients moving to Taffail practice will have on other surgeries. I am personally with Ashgrove surgery and have to wait around 2 weeks for an appointment. The patients leaving Taffail practice to register with other practices where you only have 2 buses, what reassurance can the Health Board provide that this decision will not impact on the service provided by other surgeries? Annister Bull patients, again, have the option to change surgeries, but why should they if they are happy with the care they receive? I am a patient at Taffail. Quite frankly, I'm very happy with the care I receive at that surgery. Eglwys practice has a surgery in the village and one in Pontypridd, but how many more patients can they realistically take on without compromising patient care that they already have? Annex 1, it states that the practice have found it difficult to recruit GPs. What details can the practice provide to reassure their patients that Taffail practice has done everything in their power to recruit, and how will this improve moving forward, whether the proposal is passed or rejected? Annex 2, page 9, states that the building could be considered appropriate for continued limited provision of general medical services. I'm referring to Kilbunny surgery. Has this option been explored to support both the practice and patients by reducing the number of patients having to travel to other surgeries for general services? Is the closure of Annister Bull driven by those now retired GPs to sell the building? It is evident from the comments made that this is one reason that the new GPs looking to possibly join the practice are not comfortable with. Has the Health Board explored the buying out of the GPs? The surgery has not opened since COVID, due mainly, I believe, to damage to the building. I and Councillor Paula Evans both inquired with the practice back last year when the surgery would reopen, and were told they were just waiting on the Health Board to agree repairs and they would be reopening. This was just before the announcement of the proposed closure. It seemed that we were told maybe an untruth or inaccurate information. So why should we have faith in what we are told now? Before I finish, Councillor Gronald, I would like to put a couple of questions to the board and Taffail. What conversations have been held between yourselves and Valley Lake Pharmacy on what services they may be able to provide? Has the Health Board explored all avenues available to find another practice to provide this much needed service in Kilbunny? From myself, to conclude, I would ask the Health Board reject the proposal put forward by Taffail practice And if Taff Vale have no desire to reopen the surgery in Kilbenny to do what it takes to ensure we have a local surgery, as unlike other communities, we don't have any other option. To conclude for Ennistabul, I too am asking the Health Board to reject the closure of Ennistabul surgery and explore how the building can be released from the retired partners and reopened to serve the community of Ennistabul. I challenge you to spend a day with me and use public service buses to get the surgeries mentioned before making your decision on Ennistabul. My final comments, I draw your attention to your agenda today, specifically 11.2. How did we do in the meeting? Have you allowed open and balanced discussion? Have you received sufficient assurance from a range of sources? Have you considered your values? You're about. Thank you.
Thank you, Councillor. David, I'll come to you. Thank you.
Good morning. I know members and those in attendance will have taken time to consider carefully the paper submitted, so I will pick out a few key points. In particular, I want to provide assurance that we as a health board have followed due process. In the public engagement process, all views have been considered alongside the application of the practice, and the recommendation of the board to approve the application is based on the sustainability argument the practice makes, with their commitment to deliver the mitigations outlined in response to the public feedback. Our commitment within the primary care team on behalf of White Health Board to ensure, should the application be approved, that these will be delivered. Above all, we work with the practice to ensure all patients have continued access to high quality primary care services that the two patient populations expect. So, just to give a little bit of detail on this, it was General Medical Services Contract Variation Group which first considered the application. At the initial meeting on the 29th of September 2023, no decision was made and public engagement was advised. Lice Cymru are in attendance at that group and have been involved and overseen the public engagement process throughout. And in the regional director's letter of the 18th of July, Lice have provided us some assurance that the actions taken by the health board have been reasonable in terms of process, and our actions we've been thorough in ensuring people affected by this proposal have been given sufficient opportunity to have say, that the health board have heard and acted upon what's been said, and that the concerns have been reflected on and addressed within this final proposal. Ultimately, following the public engagement, Contract Variation Group accepted the application made by the practice on the basis of sustainability. This was not an easy decision. Group members understand the strength of the agreement. But providing a range of services for a population of 16 to 17,000 patients over 5 sites has become extremely challenging. The demand for urgent same-day care and complexity of long-term condition management of primary care is far, far greater now than when I first became a GP in this area 16 years ago, and this pace of change will continue. Future primary care is set out for us in a Healthier Wales and the primary care model for Wales, and it's based on multidisciplinary working and training, where GPs acting as senior clinicians, more like hospital consultants, will increasingly provide close supervision and support to a wide range of healthcare professionals working in larger spaces. This would simply not be possible at present working across 5 sites, let alone in the future. In terms of access to and quality of service provided by the practice, the 2 communities affected, whilst operating from the 3 remaining sites, there have been no significant concerns during the previous 2 years, whilst both branch surgeries had been in temporary closure status. Equally, we have not noticed significant change in the list size or patients deciding to change to another practice. We know from the postcode data that patients living in Isabel, around 66% are registered with GP practice, which is not at Vale. And for Kilbenny, the figure is 41% who are already registered with GP practices based in the Pontypridd Centre. In terms of volume of services provided to 2 branches, based on 6 months of data from 2019, it's estimated that less than 6,000 appointments were delivered in the 2 branches. That's in the context of around 100,000 for practice overall. And from the engagement exercise, we understand that public transport is a massive concern, and we have heard eloquently this morning about the difficulties of the buses, which we do acknowledge. And whereas we do not have control for transport services, we certainly will use all the influence that we have with the wider partners to continue to improve services, particularly the daily side of that. In terms of listening and learning from what we've heard, our values, to mitigate the impact, should this be approved, we, as a health board, are committed to working with the practice to deliver a number of actions, which we will monitor, we will report on, we will hold to account. Dr. Reid has explained, I will briefly go through it again, an increase in the number of appointments available at the 3 remaining sites, including in particular in Glencoe. Move to 15-minute appointments, so far more can be addressed in a single appointment, and the need for repeat visits will be reduced. The practice will continue to provide home visits, and I will invite Dr. Reid to speak on the home visiting policy. They anticipate this will rise, and they are equipped to meet that rise of demand. The practice has considerable experience over the pandemic providing online consultations, which they do enthusiastically, and remote consultations. And they are committed to monitoring the demand and responding to that, should the application be. And from a health board side, whilst we note that around 20% of Kilfennan residents do not have access to a car, but those who do, we are actively exploring the car park arrangements that they've sent out at park sites, and the suggestions that you make, Councillor, are very, thank you, they're entirely reasonable. We are committed to working with the community pharmacy. Community pharmacies are often an underused and amazing, untapped source of help to patients in the community. They are such an important part of the primary care apparatus that we have. We are committed to working with pharmacy and consultant to maximise every possible option that we might deliver at that site. And to give one example of that, their name has gone forward for the list of other sites in Clontarf Morgannwg for approval for point of care testing of blood samples for C-reactive protein. What that means is it gives a simple test which can be done within a few minutes, an indication to pharmacists you might be assessing someone for a chest, throat or other infection to see if that is one which will respond quickly to antibiotics or one which simply needs advice. So it's a really useful resource which we hope to put into the pharmacy. We're also committed to looking at the other options, what means of health and care we might provide in community centres into villages. But I come back to my 3 key points. As a health board, we have followed due process concerning the application to the practice. The recommendation from the contact variation group to approve the application is based on accepting sustainability case made by the practice. And we're committed to working with the local community as a health board and their representatives to take forward the wide range of mitigations which have been outlined today and are holding to account in the 14 months.
Get anything else finally from you before I?
No, just I think just to note, this is a really difficult decision. It is a real balance of access for small communities to a branch surgery, and I think we will recognise the challenges that gives us. We also need, however, to consider the sustainability of the practice serving 17,000 residents, and the balance that is really difficult. But I think you've heard the challenges and the future need of being able to meet the population with more complexity in what we offer within primary care, the changing workforce models that we know. There's been a lot of media coverage over the last few weeks about the real challenge of sustainability in general practice, and this is a real case of that here within the Clontarf Morgannwg Health Board.
Thank you, Gethin. Okay, we have plenty of time this morning for questions and comments from board members before we bring this item to a decision. questions. So,
Yeah, thank you, Chair.
yeah, Ryan, thank you.
Yes, thank you for your various presentations. It is a balance, isn't it, between the removal from the immediacy of the location against providing better and more improved healthcare and opportunities for appointments. You've spoken at length about those, and Councillor has spoken about concerns about the travelling. Could I just ask about the transport issues? Do you have any data around how many people have had problems travelling so far under the temporary measures to the practices?
So from a personal
We've heard anecdotal. Is there any?
Unfortunately, no. There's no actual data. We haven't got any data on the numbers. All I can say is from a personal point of view. As I mentioned earlier, that the travelling is both an issue for your acute, your emergency appointments, as well as the routines. However, obviously with the routines, you have more time. You know your appointments at 2 o'clock in 2 weeks' time. It does give that individual some leeway to try and think of options, looking at bus timetables. With public transport is the option. With regards to the emergencies, I would say over the last 2 years, maybe there's been a handful of patients who said, I can't get to Evelyn. And during those circumstances, then it's a case of balance. We're trying to work out, and it's all individual, so I can't tell you exactly what it would be, but it could be a case of a home visit, which we do. It would be occasionally a video consultations, which again we offer. It could be something that's managed over the phone, because a lot of things these days are of case, try this first, and if it doesn't get better, then come in. So I would say in the last few years, there's been a handful of those discussions, and nothing has ever been a huge issue as far as I'm personally concerned.
Thank you.
Thank you. Rachel.
Yes, thank you, Chair. I first need to disclose that whilst I am a resident of Ynysybwl, I am not a registered patient with the Tarfield practice. I am, however, registered with the Eglwys Park practice, and some of the my comments, the comments that have already been made, refer to the impact this proposal may have on the Ynysybwl branch of the Eglwys Park practice. So just to note that. Having read the papers relating to the proposal and had previous discussions with colleagues in the room, I have some observations, some questions and a couple of requests for consideration by both board and the exec team, and indeed the practice, and some of these have already been touched on, so I apologise if any of these are repetitive. So firstly, I would like to, as everybody else has done, to acknowledge the very difficult situation that the practice finds itself in. And let us make no doubt that whilst we are talking about the business of healthcare and that the drivers for this decision appear to be improving patient care, we are nevertheless talking about a business which needs to maintain financial viability if it is to exist and to thrive. So in this regard, I note from the reports that there are numerous references to the unsustainable position the practice has been in for some years. And this is around retention of staff, but also before COVID, there's some reference in the papers to capacity issues there. So, this left me with a question about what attempts or efforts had been made in previous years before COVID came and clearly pushed this issue into a more of a crisis situation. Often if we deal with a problem when it's first identified, it's much easier to deal with, and certainly engaging with the communities of Kilfynydd and Ynysybwl may have helped you find other solutions that have been impossible to achieve now when we are really in a crisis point. So I also note that in the process of reaching this decision, the Eglwys Park practice has been consulted or certainly talked to, whether formally or informally, about its ability to take on any Ynysybwl patients who wish to remain with an Ynysybwl-based practice, and they cite their own capacity pressures. And so my question is, how confident are we that patients who transfer from Tarfield and existing patients of Eglwys Park will not suffer from longer waiting times for appointments if their patient list grows? And this is where my experience of being a patient at Eglwys Park comes into play, because we are already, as patients of that practice, having to wait considerable times to get a routine appointment, and the on-the-day appointment list is quite small. So if you don't get through at 8 o'clock or by 10 past, you will not get an emergency appointment on that day. So that reality needs to be taken into account. This question also applies to Ash Grove surgery, which is far more accessible than Debbie Sand, for example. Do we know the impact of a mass exodus from Taffel to these other practices? And I guess that's the question for me, is that have we actually asked the question of patients at Taffel, how many of you intend to stay with this practice and how many of you intend to move on, so that we can actually have an understanding of what the potential impact could be on those other practices. Otherwise, we will find ourselves in potentially an even worse situation. My second observation is about the depth and the breadth of the impact assessment carried out to determine which of the branches should close. And I do note some of the, the issues around storm damage and the impact of winter weather on some of the buildings. From the information provided, it seems as if so please correct me if I'm wrong, as if the decision to choose Kilfynydd and Ynysybwl branches has been based on patient list size and car ownership levels, which has been used as an indication that people can travel to other branches. I would slightly challenge Dr. Reid in the sense that, you may have only experienced a handful of patients that have said, I can't get to Rydfelyn. That doesn't tell the picture of the real difficulty that people who have managed to get to Rydfelyn have had to endure. So I think we need to do a little bit more engagement with patients now to really understand what help they need. They have the answers, so let's carry on talking to them. I would like to have seen a little bit more detail about how the patient list breaks down into age, disability, child patients, and if the patients of those children, the parents of those children, have access to a car, how often those patients attend practice now, and the various clinics they may need to attend regularly going forward, because I do think this will help us find some solutions rather than just saying, well, there's a bus. Or you have a car. So the assumption that there is a bus in Tigley Court, Councillor Ellis has already pointed this out, Ponty and Rydfelyn seems to be enough, when clearly the feedback from patients tells us that it's not that straightforward. I note the recommendation made in the final consultation report produced in April 2024, and I am encouraged to see a comprehensive list of mitigations to reduce the risk to patients post-closure if that happens. But how confident are we, and what measures will be put in place for, or already exist maybe, to ensure that if this proposal is approved, patients who feel they will struggle to get to an appointment at a branch further away will be supported and able to do so. So I'm really keen to see a detailed plan of how we are going to support these patients over the long term. I certainly don't want to have to make a decision today without being assured that we have a plan to support those patients and we don't just expect them to get on with it. Suggestions have been made that some patients will neglect their health or call emergency services instead. I refer to the earlier point about trying to get emergency appointments on the day. And so I would like to see a plan for how we will monitor the experience of patients affected if the branch is closed for at least 12 months after closure, and indeed this may already be in the pipeline and being worked on, and I would be pleased if that was the case. Patient feedback already suggests that getting an appointment at any of the Taffel branches is difficult, and the practice itself acknowledges that it has high levels of staff turnover and barely sufficient capacity now. What assurances can be provided that the situation won't become worse and that we understand the longer term impact on patients affected by this proposal? I am coming to the end. There is a strong feeling throughout all of the consultation responses, the public meetings and the petitions that the decision to close was inevitable. And so asking multiple questions on the actual questionnaire around, do you agree with the proposed closure, seems futile to me, and to have actually generated a lot of anger because people felt it wouldn't matter if they said yes, no, or otherwise the decision had effectively been made. There was a resounding no to those questions, but has it made any difference? No. So if there is no genuine and realistic chance of responses actually affecting the outcome of the process, should we really be asking those questions if we're not going to listen to them anyway? Outcomes like this do little to build trust between the health sector and its population. And so I do hope we can learn from this experience about how early engagement, and I go back to my first point about talking to people at a very early stage when we recognise that there are issues often can avoid some of the anger. It can help people have the time to understand what is going to happen and how that will impact on them, and so that we can learn for future similar situations. And so finally, it is encouraging to read the Llais opinion on the process, and that is a positive one. And despite my sadness, the two valued local healthcare assets are likely to close. I hope our experience of this process has given us the opportunity to better understand the communities we serve, what is important to them, and respect the very real challenges faced by those who need our services most. Thank you, Chair.
Thank you, Rachel. Range of comments and questions there. Dave, do you want to pick up on some of those? And
Thank you, Chair. Thank you. And Rachel, thank you for your comments. And, I appreciate the depth of serious consideration you've given us, and raised a number of valid points. I will try and pick out as many as I can. I want to offer reassurance that the public engagement was done with the oversight of Llais in entirely good faith, whereas it has not changed the application of practice. It has certainly influenced our approach, how we will, should the application be approved by board, how we will transact it, how we will monitor it, how we will report on it. And it is a fluid exercise. It is iterative. You're quite right. We need to understand our baseline, and we need to monitor what happens and respond to that. We'd be happy to provide further reports to the Chief Operating Officer's board on that. Should the application be most affected, they'll have a letter. And in that, if it is a recommendation, we can make available the information on other practices you mentioned. It's a health board team. We support 41 practices, and I think it's fair to say at any one moment in time, some of them are experiencing difficulties and access. They have the same staffing problems, and it's all our public sector workers, public sector bodies. So we support them, and that's a sort of flexible support. And we monitor that situation. Every practice through regular escalations, data to cover practice, maybe Ashgrove or Takewood Spark starts to experience difficulties. The first thing they do is they report that to the primary care team. We act to respond. And we will certainly be having those conversations should the application be approved immediately with Takewood Spark and with Ashgrove. We have not seen over the last 2 years a significant change in the sizes within the locality. That's not to say we will not, but we take some measure of reassurance about that. We're not complacent. There may well be changes. I'll let Dr. Reed in a moment just explain the journey the practice has been on. I don't think it's been easy. I don't think they want to get to this point. It's always a difficult balance of time of these matters. The practice could have adopted an early public engagement, raised the profile of the difficulty of facing with the population, with the representatives. Downside of that, it's a great sense of anxiety it would have created, and with the social media savvy world we live in, I think it would have quickly exploded. We would have been here probably in an emergency session, trying to respond and to sort of counteract that. So I don't think that would have been necessarily helpful. The mitigation detailed here are very much headlines. I appreciate you want to hear more detail as we go forward. If we go forward on that, we're very happy to do that and to take on other suggestions. We, the health board and the practice, do not tend to have all the answers. There's lots of detail we've mentioned today, particularly on transport. Yeah, the practice, I don't think has an active participation group, but they've given an undertaking to restart one. I think would be very helpful. I hope that covers some of your points. I'll maybe let Stefan, Dr. Reed.
Before I bring Paul in, Stefan, anything else you want to come back to in terms of the questions that Rachel asked?
Yes, quickly, just to answer some of your questions. There wasn't, a plan 10 years ago to close these branches. COVID was the big trigger, if I'm honest with you. And for those of you who are not aware, during COVID, what we had to do was to close Killarney and Dunstable purely from a staffing point of view. We used Glencoe as our hot site and the other two as our cold site. And then we're talking 2.5 years of not having these buildings open. We attempted to open them a handful of times, and on each occasion, I promise you what would happen. We'd have staff sickness, usually admin, And so then all the clinics were moved and everything was moved back more centrally. So we attempted to. And then these buildings came into disrepair. As terrible as the optics are, in Kilbunnydd, there was a pipe burst and it absolutely ruined the entire building. All right. And that was around the time where we were opening it as well. So this has been a 3-year process. And over the last year, we've had numerous discussions in our meetings about it, some in favour, some against. And over the last few months, because of the pressure that we've been taking with regards to work, and mainly I would say more admin staff turnover, because you may think it's all about having your clinical staff, but without someone to open up, without someone to do all those, there's no clinic, and that's been our biggest issue, I would say. So unfortunately, that's one of the big factors that has swung the votes. Okay.
So thank you for the presentation and also for the really valid and real assessment from Councillor and from Rachel about the challenges. I guess what I was going to do is sort of lift our eyes a little bit about this situation is a microcosm of what's going on in primary care across our patch, I mean indeed across Wales and including the UK, right? So today we're here talking about this practice, and I can guarantee you in a few months' time or a year or time, we might be talking about another practice that's got a challenge, because every practice, as Dave rightly said, is dealing with real pressures at the moment, both in terms of growing demand, an ageing population, a workforce pressure, estate challenges, financial challenges. So part of me isn't surprised in a way that we are here today, and I can absolutely understand why the practice is having to make a really, really difficult proposal to us, because they're looking at how they sustain the services for their whole population. I think we need to, obviously we're here talking about the 2 branches and the communities that they serve, but the practice has to take a look at how do we make sure we sustain the service for all of our 16,000 patients to make sure that that's sustainable. So I do understand the pressure they're under. I think what this also says to me is, as Rachel says, we need to be probably starting to have further conversations across our health board with all of our communities about these challenges. We've had similar conversations, Liam will know, back up in my steg about challenges up there. We've had similar conversations in other parts of our patch around primary care challenge, but I'm not sure that really we've perhaps been as effective as we could be in describing the challenges that all of our practices are facing on a daily basis, and the pressure that brings to those practices to have to make tactical ad hoc decisions to close today or move this, or and that results in frustration for practice. And I say this all the time at the moment. If I was to go and ask anybody in our communities, what's your biggest issue with the NHS? They say, I can't get a GP appointment. That would probably, more than I'm waiting for an operation, more than I can't get, this or that. It's largely down to primary care, and primary care is the route in to pretty much all of the health service. If you want to go and get you need joint knee replaced, you've got to start off at the GP. If you want to go get a referral to mental health services, probably largely have to go through the GP. So I think we need to do much more as a health board to elevate the profile of primary care in our communities and listen to the challenges that we're facing in primary care and help our communities understand how we do this. Now, I've had meetings with, John and I meet regularly with local authority 3 leaders. We've had David and colleagues come along and talk to the leaders about the challenges that we have in primary care. We've briefed the MSs about this challenge, we briefed the MPs about this challenge. So I do think we need to be having a bigger conversation with our communities about this, because there's also a change in the way primary care is delivered. We've heard a lot from David and Stefan about moving away from just a GP only model to a team-based model, which is really the right way forward. But we also know that many of our population don't like that model, and we hear feedback from people saying, but I want to see a GP. But the reality is we've only got a small number of GPs, and we need to be expanding the use of other professionals in how we do it. So I think there's something about how we broaden our perspective out into this. So that's more of the sort of the bigger picture conversation about primary care sustainability, because I think unless we do something now to change the model of primary care in our communities, these sorts of situations are going to occur ever more regularly. And really sadly in our communities, we know that we've already got some of the most deprived communities in Wales. That leads to poorer health outcomes, that leads to worse inequality, and therefore it's a never-ending perpetual cycle. So we've got to do something as a health board, I think. So I think part of the learning from this process is that we need to be doing more to elevate the profile of primary care and have that conversation at the board, but also with our communities. On this particular practice challenge, I think the issue of transport is being raised, and it's a really, really important thing. And again, sadly, this comes up in many conversations about services of healthcare across CTM. The transport issue is front and centre everywhere we talk about this. And I do think there's a conversation we need to have about whose job is it to make sure we've got the right transport, because we're the best one in the world as the health board. We don't commission the bus services, we don't plan the bus services. So where can we be talking to the council, Colin? And maybe this is part of the actions out of today, is maybe a bit of a focused piece of work we need to be doing with the practice, with the councillors, with the local authority, with the bus companies to talk about this, because I think we can't keep raising this as an issue and just saying, oh yeah, it's a problem, and not actually taking an action. So I think whatever we decide today, be part of the action plan, needs to be a broader conversation with partners and stakeholders about how we might be able to start to look at that. We've talked about this as part of our thinking around clinical services for the future, and maybe we do need to be more designing a sort of community-based model of transport that is supported by the health board, supported by the local authority, some sort of minibus type model service that sort of drives around the local. I don't know what the answer is, but we need to do something, because we can't just keep accepting that transport is there as a problem and not doing something to deal with it. I think there are points, as David mentioned, that we can control as a health board. So the parking issue at Dowie Sand, that is our facility. We need to look at what we could do differently with that. And I do think the suggestion that was made about looking at moving staff parking off site to try and free up parking on site at Dowie Sand for patients is something we will take forward, and we are doing that as a key action. And the final point to make is that point about the pharmacy. I do think we have an opportunity with the pharmacy there to do something quite innovative and different, and I think the pharmacy are interested in that opportunity. In Wales, the pharmacy contract has a lot of flexibility and a lot of opportunity to grow and develop minor illness services, alternative models. Actually, so there is something that we could be doing, perhaps to provide more sort of services in that facility that is still local to people's community, whilst protecting the GP capacity to focus on the people who really do need to see the GP. So I do think there is potentially an opportunity to turn this into a positive, to say, well, how do we use that community-based facility, linking up the pharmacy with the GP practice to make sure if they see somebody who's needing to see a doctor, they know they can get a fast track back up to the GP if they need to, if the pharmacist thinks they need it, or getting telephone advice, that sort of thing. So I think there are alternatives, but for me, the key action out of this, if we agree to the proposal, what I think, to Rachel's point, we need to be really clear is having a really clear plan, and that plan is developed in conjunction with the local authority councillors, with members of the community, to say, if we do this, these are the things we know we need to do, and we will commit to working with that community or those communities to make sure that they are part of helping find the answers to the really valid and important points that we raised today as concerns.
Thank you, Paul. Any further questions or comments from? Sorry,
just an observation, really. I think that's really helpful. We'll take a macro view of the area, but that doesn't address in the short term some of the issues that the councillor raised and that Rachel has raised. Mm-hmm. So I would just like some assurance that in the short term, some of the mitigations that we've here talked about from the practice are accelerated, if I can say. So we need to know that if there's somebody who just can't get to the practice, they can have an online call or they can have a home visit. Yeah. And I don't know what our position is as health board in terms of monitoring that, to know that we would be content. So macro stuff I get, but in terms of this application, I would like some assurance that those smaller things that can make a big difference to those people who will be the most affected, or are probably least able to help themselves, will be dealt with as part of mitigations.
Yeah, I think I think that point is really important. It builds on Rachel's point. And if this decision is taken today, how do we ensure that we as a health board learn from that? About what does this tell us? Goes back to Paul's point. What does this tell us about the shape of primary care in the future? And it is not the too distant future. When we are talking about things that potentially can happen in the next few months, within the next few years. We're not talking about something that may materialise in 10 to 15 years. We've got challenges around sustainability and quality of services that are very present now. And constantly we are involved in conversations with communities who say we feel disconnected because of the challenges around public transport. And I think as part of our work with the leaders and the chief execs of the local authorities, but I'd also say your work, Councillor Ellis, and yours, Gerard, as a county councillor, what can you do internally back with your authority around the robustness, the commissioning, the planning for local bus services? Because there's only so much a health board can do. This has to be done in partnership. And if there are challenges around that robustness and that reliability of a public transport service, what is that planning that's going to be put in place now to respond to communities where some decisions may also occur of this nature, if this happens today, in the future? And I think we have to say to the local authority, where we are now with this GP practice is potentially where we could be in 6 months to 18 months to 2 years hence with others. And those same concerns will be raised with us. It's that constant balance we are having to contend with between quality, sustainability, delivery of a robust primary care system, and making sure people can physically access it. So I think that point around, for those people who physically cannot get there, what assurance is there? What reliance can we place on the ability of the practice to provide those online consultations so that people can feel that their needs are being addressed? But this is just one example of where we can all see, I think, primary care potentially being reshaped fairly soon in terms of what that offer looks like. Stefan?
On your point, we work with a lot of departments, so paramedics, district nurses, as well as pharmacies. And so it's not uncommon for us to get a phone call. A paramedic has visited a frail person and said, listen, I don't think they need to go to hospital, but they need X, Y, and Z. And then either we'll arrange the whole visit or we can manage over the phone because they're already there. Pharmacists will ring us directly. They've seen the child. It's this particular rash. They've taken a photo. They've sent it over to us. Oh, we think it's this. It's managed from afar. So we are doing a lot of these things. I totally agree that, unfortunately, I think we are a bit of a guinea pig as this practice. I do feel that we are, unfortunately, maybe one of the first that are going through this transition. But hopefully, as previously mentioned, if we get the right solutions now, that we can be used as something to view from other practices in the future.
I appreciate, obviously, taking on board the seriousness of primary healthcare in general, which is a good thing, and things have changed since COVID. We've been forced to work differently, forced to access services differently. It's not from choice. But I go back to that lady's question there. If this is decided today that the practices will close, which I, to be honest with you, I think it will. What I want from today going forward, it's okay to say we'll do a plan, we'll do an action plan, we'll propose it. And yes, I understand that we'll get that. But I want to know today, to take through to patients in Anisabel and Kilbunny, what is now in place ready from today, if it's closed, for those patients going forward. And I don't think that's unreasonable to ask.
Could you address that?
Absolutely. So, one thing I would say, these branches have been closed for 3 years. So we can take it back 3 years and the changes that we've made for the last 3 years. Now, we have more home visit slots. So each GP will see at least 2 visits per day. That's up to 8. So there's 16 home visits. We usually get about 5 to 6 requests. So we've got far more than we need. All right. As I've mentioned, in Glencork, we've increased our services. So previously, I would see a patient in Unsable and they'd need a blood test on emergency ECG to avoid admission. They would then have to travel to Llewellyn and get that done on the very same day. So they'd be on that transport anyway. Now they're getting everything done more locally in Glencork. So things have been put in place. And as David has mentioned, we've increased our appointment times from 10 minutes to 15. Now, it's a 50% increase. You can get a lot out in that time. So it reduces the need to come back and again. And as a practice, I can assure you that no doctor will ever turn the patient away being late. Okay. And we will make sure that the patients are seen based on clinical, I can't say that we're going to see everyone just because they
But to
want
reassure the councillor, maybe what you need to be doing is describing all of those things you've just
Yes,
described
exactly.
in some sort of communication to patients to give that. I mean,
Yes.
it's not going to, it's not going to take away the fact people feel a sense of loss, but at least if people can see all the things you're putting in place to try and mitigate the impact and have it written down for them, rather, because it's the usual story, isn't it? Otherwise, people hear things differently. They chat to someone who says, "Oh, you can't get this, you can't get that," and actually, if you've got something that's written down that describes all the things you've put in place, I think that would probably help. But I also think what we need to commit to doing is the piece of the plan we put in place to mitigate this as a health board with the practice. We need to commit that that's shared, and that there's some sort of group, including councillors, including local residents and people, practice participation group, all of those people that come together to make sure that the things we say are going to be done do get done, because we've all been there before. We say, "Oh, these things will happen," and then 6 months down the line, it hasn't happened, and everyone goes, "Well, that would never happen."
Just one other comment, if I may, Chair,
Sure.
please. Yeah, if you thought about, I don't know if it happens now, it certainly doesn't happen when I've been there, a wraparound service within the surgery. So from what I mean, you have a GP appointment, you go and see the GP. GP says to you, you have a blood test. You then go make an appointment with a nurse. 2 weeks later, you get your blood test. Then you have to make another appointment to come back and see the GP for the results of that. That to me is just labouring it out. But if one person, if you need go to the doctor, if you're making the effort to go on public transport to get there, you see a GP, you need blood, have you thought about designing that service within the surgery that you say, right, take this now to the nurse down the road there, down the corridor, you can have your blood test here, and I'll see you back in a week.
One stop.
That would be a huge help.
And that is what we have implemented. It's
When, because that's what's happening with me this week.
I would say it's clinical need.
Yeah.
Some people need blood tests today. Some people need to trace their heart today. Some people don't need it today. And so it is all based on the individual. But and that's the benefit of having the multidisciplinary team in all three areas. You do need a blood test. You do need.
So you're not taking on board my point of people then having to come back and come back and come back.
Yes. I would say it is based on clinical need. There is a balance, isn't it?
Let's go. Just Geraint, you want to come back in?
Yeah, just very quickly. I mean, I represent, as you do, the village of Llanharan and Bryda on around the Cynartaf County Borough Council, and I have done for 20 years. These questions have been raised. I know Paul will know, and others will know. There have been issues around the migration of services away from what we have, which is a satellite service from the main practice in Pencoed. And there has been migration of services for years towards the main practice for the very reasons that you've been raising this morning, which is better management of staff and other resources, and providing a better service from one location than from two in this particular circumstance. And I think, it's a question for the 20 years that I've been a county borough councillor, there has been a perception, and I'm sure my colleague over there will agree with me, and we all appreciate, there's been a perception in the public that the public service generally across all the sectors has been in some form of retreat as we manage the financial crises, several financial crises, and the austerity and all of those things. And the question has always become, as public servants, how do we provide the best we can with what we've got? And unfortunately, depleting resources. And so I think that's the overarching question, is what can we do? How can we provide the best we can for people with what we've got? And I think that's sort of where we are with this conversation. And with advancing technology and other measures, I think that provides an opportunity to do more with what we've got. But so I have sympathy with all of the sides of this argument, really, that representing a population which feels like things are being taken away because they've always had them close by, and the medical and the clinical and other expert advice which says, well, actually, we can give you a better service if we do it in a different way. So, and I think your point is exact. Most people have responded to those changes in my area. Most people have been able to cope with change. There are a few who will find it more difficult because of their lack of access to a car or whatever. And those are the people we need to have uppermost in our minds going forward. But I think that's the overall, what can we do best for people with what we've got? And that's where we are.
Yeah, I was just going to try and bring together, if I may, the comments and the agreed actions that we have as a health board, because I think you're absolutely right. The concerns that have been raised are real, they're reasonable, and we need to ensure that the commitments that have been made by practice, we as the commissioner hold the practice to account to deliver those, and that we take our responsibility around protecting the population in that way, as importantly as we can. The first key thing, and I think it comes back, Rachel, to the point you made very early on around that engagement, the soft engagement. I think one of the challenges probably has been the lack of a PPG. Now they can, they need to be a patient participation group within the practice. So most practices have a facility. I think what we are really clear about, and we have the commitment from Taffel practice, is establishing that. And I think that becomes the really first important point. And how we make that work, not just in a face-to-face environment, but actually in a virtual environment. For those that, so that you can get that representation from across. And I think one of the big important bits is covering that broadest population to get all of those opinions, because you want to hear the cross section of your practice, not just certain interest areas. So that commitment is clear, and I think that assures us in terms of that ongoing engagement. I think the point that probably makes sense is that we set up over the course of the next 12 months a number of sessions with the primary care team, with local councillors, with the practice, with the PPG, so that we're testing that those things that we've collectively committed to, including the actions the health board is going to take, are being delivered around that. And where we are seeing challenge, that we're clear about what are the additional mitigations we need to put in place. I think we know home visits are always a point of contention. I think what we've heard very much is that the practice has capacity. What we've got to be really clear about is how that's used effectively to those patients that genuinely cannot get to the practice. But recognising more and more of our delivery is done remotely, and particularly with the rollout of electronic prescribing, that makes life even easier, because of course your script is automatically delivered to your pharmacy to collect. It's not about having to go to the pharmacy to pick up the script to then take it. All of those things are really important pieces of how we can still deliver much of that care locally, recognising there will always be a requirement for some patients to be seen face to face. Because of the severity of their condition, they need on their chest list, 2 big hands on their belly, and that's a really important part of how we address that. We continue to work with some local transport providers, because I think we recognise, and Amanda's clearly articulated some of the geographical challenge and topographical challenge of the environments around that. And so we are continuing to work, and there are some community providers who will provide support to get to this. And we need to work with the community and share that, and encourage the expansion of that support to get those patients to the GP practice. We touched on Dewi Sant, just to be really clear. We have already got some parking in Sardis Road car park. We intend to make the parking at Dewi on the Dewi Sant to be patient only, so that we will move our staff off the site to ensure that we maximise the availability of parking. We're also in conversation with RCT Council because we know there are problems with the pavement quality going up to Derry from the railway station. So we are working with RCT to try and accelerate the repair of that pavement to improve access. I think a number of those mitigations are in place. The challenge now is monitoring them and continuing. So what I would propose is that I will bring back, through the executive group, an ongoing assessment, and that we perhaps will then bring that through a probably PPF as the subcommittee, just so IAM's got that site on there. But we will continue to, we want to make this is really important to work for the needs of the broader population, but also the local population. And we've got that duty as a health board to balance that. And as Geraint has articulated, that really big difficult equation to balance. But we do need to ensure that we still safeguard the access for populations in Anisable and Kilbunny should we approve this case today. But there is an ongoing commitment to the question Helen we've raised, that we will ensure that the agreements that we've had and will continue to iterate are monitored and driven.
Thank you for that, Gavin. That's reassuring. Philip. Thank you. So I'm Philip Daniels. I'm Director of Public Health. Hello. And I support what Gavin's just outlined, and this just to respond to some of the comments that have been by Helen and Geraint specifically. We're dealing with two related issues here from a public health point of view. So there is the inverse care law, and that's what Helen was describing, that those that need care the most typically have the least access to it, right? And also, not specifically in this case, but more broadly, have the most difficulty in having their voices heard, or let's switch that round, are often not listened to in that process, right? So their input is not given. There's also the concept of universal proportionalism, right? We work within a system, the NHS, that is free at the point of need, and we provide services to anybody when they have that need. However, we need to ensure that those people who have the greatest need get the greatest support as well, right? And obviously, responding to Geraint's point and Paul's, that this is a common theme that will come up time and time again, that we'd like to see more of this, but technology is shifting. So that balance of how we do things is constantly shifting as well. So just to support Geraint's work, the work that Geraint outlined there will be underpinned by those principles of the inverse care law, providing greater support to those that need it, and universal proportionalism, so ensuring that any decisions that are made will be available to all, but obviously that we will focus greatest attention on those that need it.
Okay. Can I thank all colleagues for engaging in the discussion this morning. Very grateful to Councillor Ellis and Dr. Reid and to Dr. David Miller for being with us this morning. What is in front of us today asks the board firstly to note the reports that have been laid before the board, and there's a recommendation to the board that we approve the application to permanently close the branch sites located in Kilbunny and Anisable. Can I ask all those who are in favour of the recommendation to raise their hands, please? Are there any who are against? Any abstentions? No. Okay. The application is approved. This is not something we do easily. It is not something that we do without proper consideration. I hope that this morning has demonstrated that we are taking our role very seriously, but obviously, there is the commitment. I'm pleased with the reassurance that we have in terms of what happens by way of next steps. I think this requires further engagement, further involvement, and I've already said to the Chief Exec, I think here is an example that we must use to further our conversation with our colleagues in local government around those challenges of access, because what we face today, as I said earlier, is potentially what we will face fairly soon in the future. And collectively, I think it's incumbent on all of us to address those challenges of access. Because we do not want our patients, our communities missing out on the care and support that they need. But that requires a collective effort and also a robust response and input by the local authority as well. So thank you very much for joining us. We are going to take a break for a 5-minute break. If I can ask you to return sharp at 10:30, please. Thank you very much.
Actually, listening today, thank you all very much. I know it's a very difficult decision.
Yeah.
Of our prelims, but yes, and I will look forward to working with you all in the future and hearing what the plans are and inviting put things forward for patients of any development. So thank you very much.
Thank you. So Joanne, Dawn and Leah, you'll notice that that radiator over there is blisteringly hot, and for some reason this one is as well. So I apologise in advance if you think this room is unbearably warm, because it is. But it's not something that we've caused ourselves. Can I offer a very warm welcome to Joanne Cotter? Joanne is here to share her patient experience, her patient story with us today. And to start, can I say a very big thank you to you for being willing to come here today with such bravery, really, to offer your perspectives to the board. And I think it's very important sometimes for the board to hear stories which can be very challenging and very difficult to listen to, but it's very important that we hear the messages from our patients and our families about their experiences. So Joanne, thank you for coming this morning. And if at any point this morning you need to take a break, please do so. It's very flexible. We're not in any rush, okay? And very warm welcome to Dawn, who's a senior nurse within our paediatric service, and also to Leah as well. Thank you very much for joining us. So if you're comfortable, Joanne, I'll come to you and you can walk us through your story. Thank you very much indeed. Thank you.
I'm just going to give a little bit of background. Really.
Sorry, apologies.
Yeah, that's okay. So I met Joanne and family, management of patients on paediatric unit at British Hospital for a very short time before he was retrieved to Cardiff and then went on to Bristol and then subsequently passed away sadly in Bristol. And you know, as part of our normal practice, we look at our own practice as part of that, and we did our own internal investigations. And I met Joe Christian as part of that, discussing that report after that report. And during that meeting, a lot of things came up in our talk. And following that, I asked Jo if she would be happy to share hers and Elijah's story as part of our patient experience, which she So I'll take my hand over to Jo.
Thank you.
So I'm going to apologise first that I'm going to put my head down and read it from this book. Just
That's absolutely fine. Yeah.
It gives me a distraction and you're all looking at me. Hopefully it tempts me to have a little bit of a detachment from the story rather than just reading off the page. So my reason for agreeing to do a patient story was in the hope of helping others. I know there are many fantastic doctors, nurses and midwives, but in my experience I feel some have become desensitised. I felt I needed to do this to remind those that whilst this is a job to you, certain things you say and do, probably totally unintentionally, can massively impact an individual. So I know you're obviously aware of my heartbreaking loss of my son Elijah, but I'm just going to provide you with some background information. Whilst I was ecstatic to find out I was pregnant with Elijah, I was also nervous. I'd suffered a bad experience during the birth of my firstborn and miscarriage and an ectopic pregnancy 6. Luckily, everything went really well, and I received great care from Prince Charles Hospital. We were discharged the following day after he was born, and we were all living in our new baby bubble. Our daughter was besotted with her new baby brother. A few days later, Elijah was struggling with feeding, and he was suffering with constipation. He had jaundice when he was born, and the community midwife had explained these were common symptoms. On our second home visit, I explained the symptoms were ongoing, and we were told the jaundice meter had been sent off for maintenance and advised to visit the labour ward for his levels to be checked. Myself and my husband visited the hospital with Elijah, and the test was carried out by a nursery nurse who informed us that the reading was within the acceptable range. I voiced my concerns in regard to his feeding and constipation, and she said that the community midwife that had sent us to the hospital hadn't mentioned this and to take it back up with them. She then gestured to Elijah and said the following words: "See, when his mouth is moving like that, it means he's hungry." And I remember this moment so vividly, as it instantly made me feel like a terrible mother. I'd had a previous child and was fully aware of a baby's feeding curves. I felt like bursting into tears. Any mother can relate to high emotions post-baby, and being a professional in the field, I thought that she would have been more aware of this too. I quickly left the room feeling as though my concerns had been dismissed and completely humiliated. Already feeling fragile, I walked towards the exit doors, carrying Elijah in my arms. My husband had dropped us at the entrance and gone to park the car to save us having to walk in the rain and to carry him in our heavy car seat. I'd had a section 5 days previously, so it seemed the best option at the time. As we were leaving, a member of staff literally shouted, "Excuse me, do you have a car seat for the baby?" I quietly explained the situation and wished the ground would swallow me up. I cried the whole journey home. I was worrying about what others who had heard the comment would think and just felt like a terrible parent. A few days later, Elijah completely stopped feeding and became very lethargic. After a call to out of hours, we were back at the hospital. Elijah was originally diagnosed with sepsis and then bronchiolitis a day later. I was overcome with emotion and worry. I was also feeling guilty for leaving my then 4-year-old who had never really been away from her mother. COVID restrictions were still in place and only one parent was allowed to stay at a time. Naturally, I felt I needed to be with Elijah, but at the same time I felt torn. Elijah seemed to be deteriorating, but my husband was staying positive. I admit I am a real worrier, but this was different. I just had this gut instinct that things were not going to end well. I couldn't stop crying and I was very emotional. A doctor asked me numerous times if I had a cold, as my eyes were constantly red and tearful. When I explained I was just really upset, he asked me, "Why are you crying all the time?" My initial thoughts were, are you seriously asking me that question? My son is really unwell, I'm in unknown territory and my hormones are everywhere, and you're genuinely asking me why I'm upset. He continued by saying babies become unwell very quickly and they recover very quickly. Listen to your husband, he will be fine. I've since learned that this particular doctor in question is amazing at his job, and I'm almost certain he had no intent to cause me any further upset, but in all honesty, he did. It's a moment I've repeatedly played in my mind since losing Elijah. At that very moment, I was made to feel like I was overreacting. We lost Elijah a few days later at Bristol Children's Hospital to cardiomyopathy caused by enterovirus. Our life changed overnight, and it will never be the same again, and quite frankly, neither will I. I have suffered with my mental health since, something I was too embarrassed to address. However, a few months ago, when things got really bad, I finally plucked up the courage to seek help. I had an appointment with the doctor a few sessions later, after with the perinatal team. I explained how the anxiety and constant fear of something bad happening to my children was basically taking over my life. His advice, and I quote, was to get past it. He told me I needed to get past the fact I'd lost Elijah and that he has to deal with death on a regular basis. And whilst it's not nice, he has to get past it. Logically, he's right, and in an ideal world, when we lose a loved one, it would be so much easier if we could just get past it. But that's not the real world. I will never get past losing my son. Neither do I know if I want to. As the pain I suffer every day is all I have left. Losing a child is completely unnatural. So to even suggest such a thing is just ridiculous. He chose to become a doctor, knowing that with that profession naturally comes having to witness death. Death in patients you barely know. This was my baby boy. I did not choose this path. I don't expect anyone who has not been in this heart-wrenching position to fully relate, but I do expect some empathy. I left the appointment and I cried most of the day. It had taken me 18 months to finally admit to needing help. It left feeling like I was being overly dramatic. Obviously, I can only speak for myself, but I'm hoping from some of the points I can get across, there may be opportunities to help others. I understand how busy you all are in your roles, but the smallest bit of empathy and kindness can really go a long way. You may not have the ability to change the outcome, like in my case, but you do have the ability to make a situation more bearable. I know firsthand how sometimes words can affect your whole experience. Please just stop and think and put yourself in their position. Take the time to reassure them that their concerns are valid. Your actions can massively impact a person, and it's up to you to make it a positive one and not just treat it like another part of your shift.
Joanne, thank you. Thank you very much for being able to share that story with us this morning. I appreciate how difficult it is to just to sit here and to relive those moments. Usually what I try and do as a chair, when we have patients or staff come into our board meetings to talk about their experiences, we generally ask if colleagues have any questions or thoughts. I will ask if that is the case, because again, Dawn, would you like to pick up on those?
Just part of the slides, you know,
Yeah.
We have had some learning. We've kind of looked at what's happened.
Yeah.
I don't know if Emma can put that up. You can see communication is key throughout the whole story, and you know, having those helpful values and behaviours about respecting. And I guess as a team, you know, Joanne kindly came in and did an audio version of that narrative, which has been really powerful. And as a team, we thought, how can we share? We can share it very big meetings like this. But how do we get this across to those people on the shop floor, those that are giving direct care? And I think for us, it's been, you know, making sure that we share that audio narrative with the slide, and I've done it on a number of occasions with healthcare support workers, with students, with doctors, and when they hear this, there's kind of an immediate light bulb moment, kind of like, oh my gosh, you know, I've done that, or I've behaved that way. So it's just bringing us back to, you know, making sure that we are listening and respecting and taking time and being kind when people have concerns. To allay those fears, I suppose. I think it's really important that, obviously, Joe mentioned the GP. How do we get that across to our primary care colleagues, maternity colleagues? This has been shared with maternity colleagues. And I know Joe we've had lots of discussions, obviously. And one of those discussions was that you'd gone to Cardiff and spoken to the cardiologist there, and they had Elijah's notes there, and there was a big tape on those notes saying deceased patient, and that was very traumatic for you. Yeah. So we've contacted our bereavement team here, how we can, you know, if we're in that situation, how can we change that? So Donna, our lead here, and we're looking to get covers for people with a rainbow on, so it's not as
Just seems really cold. You know, I think I said to Dawn when I walked in the room, I thought, going back to Cardiff, I was worried that I was going to have any meltdown like I just have, sorry. And I thought, oh, no, I'm okay, I'm going to hold this together. And as soon as I walked in the room and seen the file with deceased right across the front, it just made my stomach flip. I know that this is a fact, like, I fully get that, but it just seems really cold and hard. And as soon as I seen that, I went from thinking, oh, I'm going to be okay. And I was in bits really from just seeing that one word on the front of the file. So if there was, we were discussing obviously an alternative option, even it's just a logo or a different colour or a way of identifying it without causing somebody who's obviously a family member to see that and giving them a horrible experience.
And Elijah went for ECMO in Bristol, and I think quite recently that you hadn't realised how invasive that was going to be, and yet how it was the very last chance.
It was suggested obviously in Cardiff that there wasn't much more they could do for him there, and that there was a piece of equipment called ECMO which would give him a better chance of survival. I had no idea what ECMO meant. I'm not from a medical background. All I heard was, this is going to be a chance of survival, and go on and we'll do this. When we got to Bristol and we spoke to the cardiologist there, and we said, oh, you know, we've been informed about this piece of equipment. And he was like, yeah, but there are these side effects. It involves this. It's still a very, very low chance of survival. is that something you want to do? Had these options been given to me whilst in Cardiff, rather than me just trying to Google it and find out what it's about on the way there, at which point I'm in no position to really read anything anyway or take anything in, then we wouldn't have gone to Bristol. We would have stayed in Cardiff, because I said to Dawn the other day that Bristol isn't far away really. When you're in this position and you've got a child here and family here, these horrible things are happening. You want to be as close to home as possible. And even though it's only an hour and a half away, that hour and a half caused me major issues in obviously trying to get things that we needed, and my daughter come in, and we made all these plans that if we had to stay in, what we were going to do. And in reality, we didn't have to really go through any of that. We could have just stayed in Cardiff had we been more aware of what it actually entailed. So we did speak to the cardiologist in Cardiff, who said they would consider maybe doing a leaflet or something just to give to parents so they can have a better idea of what it's about. Because as I said, I wasn't aware of anything to do. I've never heard of ECMO. And I think unless you've worked in that sort of field, you wouldn't know what it's about either. You just basically clutch at any stroke that you think you're going to save your child's life, really.
Jo's given me permission to share this story across Wales, so I will present this at the All Wales Senior Nurse Forum this week, so I can have those discussions with the Cardiff team as well. So
Those points on the slide are so important, and part of this process for us is not just to listen, to learn, and then to act where we feel that things need to improve, and for us as a board to be assured that that improvement is embedded. So
I just can't imagine the challenge and trauma you've been through, and I really am grateful for you coming along today, because it's really important that we hear these stories at our board. And I think many colleagues might be sitting here thinking, well, isn't that awful? Those doctors or nurses have said those things. And I suppose we also have to remember these doctors and nurses are dealing with so many different people on a daily basis, aren't they? I genuinely don't think anyone's intentionally says these things. But what it just highlights is one comment in a rush as someone's running down the corridor or rushing off to do something else. That moment for you was the really important moment. And it's really difficult for staff because they have hundreds of those moments every day. And it's so easy to say, oh, we were busy, or we were, we hadn't realised that was going on, or we hadn't thought about that. But it just, for me, just shows that we've just got to constantly remind all of our staff, doctors, nurses, therapists, HCA, everybody, that your words for that person at that moment are the most important thing, because we're not patients, we're not clinicians, so we put all of our faith, and we go into this weird scenario, don't we, go to hospital where you put all of your own, you are completely at the mercy of what the professionals are telling you, and you listen to what they say, positive stuff and also the really difficult stuff. And I think for me, what I'd probably like to talk to Greg and Sally and others about, Lauren, is how do we build in sort of communication skills training? And I know people do that as part of their training when they're students, but often, dare I say, these are clinicians who are perhaps 20, 30 years post-training, and maybe we just need to be constantly refreshing that. And it sounds like that's already happening in the paediatric department and maternity. But my challenge is, how do we do it more broadly in outside of those areas? Because I can guarantee you today, I could have had a bereaved relative who've dealt with a frail older person in one of our hospitals who probably would have had some similar experiences. And I think, in terms of our learning as an organisation, this is about how do we embed the real-time experiences, and the really sad example that you've given us today, Joanna, that can't be how we behave. That's not acceptable in our organisation. And it's not that people are intentionally doing it, it's just reminding people, holding that mirror up to people and saying, that comment, the one that you just made about the car seat, I was thinking, oh my goodness, and Greg was thinking as director of nursing, thinking, oh, what nurse, but I can just see how it would happen. Some of us, people have been worrying about, are babies being taken out of the unit properly? Are they safe to go home? Somebody's doing it with the right, intent, but just the delivery of it at that moment wasn't thought through. And it's just that reminding people of that challenge, I think, and thinking what we can do as part of our ongoing training and development of our staff to continually refresh that for people, remind everybody of the importance.
Kath.
Yeah, I just want to say, I'm so sorry for your loss. I'm so sorry for the experience that you had. Yeah, it's and how brave you are at coming here. I'm going to wet up now, but I just wanted to say thank you, and we are listening. And I totally agree with what Paul said. You need to get these messages through because it's about acts of kindness as well, isn't it? When you're in that whole sort of trauma, different world, you need those acts of kindness.
Sally and then Sally.
Yes, Joe, I'm Sally, I'm the Deputy Medical Director, and I want to say this, I'm so sorry for your loss and so sorry for your experience. And thank you for talking today. I think it's so important that we do hear this and that you're willing to share your story with all the groups that you are sharing it with. I think Paul's right. We need to keep reminding our colleagues and ourselves about these instances that and so thank you very much, and we need to keep doing it.
So Sally.
Carolyn's actually.
Oh, apologies, sorry.
Thank you.
Carolyn.
Very much.
Sorry.
Hi, so I'm Carolyn. I'm one of the independent members and I also chair the Quality and Safety Committee. Thank you so much for being here today. I just think that the power and the impact of hearing people's true stories is so important. I was involved recently in one of the 15 steps visits in maternity, and that involves service users and a group of people walking around looking at facilities, etc. And it's the first one I've done. And a lady on that had very sadly had an experience of losing a baby at 18 weeks. And just her perspective on walking around and the feedback that she was able to give changed everything, I think. It's just interesting how your perspective, you're looking at it through a different lens and the value of what she had to say. And similarly, she unfortunately had not a great experience, but was very, as yourself, very brave and very willing to say, I want to help you see how this feels to people in this situation. And again, nothing that was intentional, but just we're busy, these sort of casual comments in the different ways. So thank you so much. And we are listening. And I just think it's something we need to do more of. And the 15 steps thing, I think I said to Greg, is something that I really think in terms of our visits that we do, I just found it hugely beneficial because you've got a really broad perspective. And so thank you.
So already agreed to join one of the
That's great. Yes. Thank you so much. Much appreciated.
So Sally.
I'm Sally Bolt, I'm a radiologist, and similarly, I would like to thank you very much for coming here. I'm very sorry for your loss. But I think what you've done is really extremely helpful, was to really minimise the chance of receiving a similar experience. My role here is as chair of the clinical advisory group, and that has representatives from pharmacy and therapies, and from primary care, so the whole of the clinical body within the health. So I'd very much like to share your audio file with all those colleagues and disseminate more as well to really increase the people who have heard it.
Great. Greg and then Gethin.
Yeah, hi Joe, we met. I'm Greg, I'm the Director of Nursing, and I first shared your story through your recording in the maternity and the Health and Safety Board a month or so ago, which really, triggered a response in us that were around the table to ensure that the board could hear your story. And thank you so much for coming in person today. And again, I'm so sorry that you've had such a traumatic experience. Then the impact on our staff, on you, just added to that. We've been doing some work, Joe, in relation to the number of complaints that come in to the health board. In fact, communication in its umbrella terminology is one of the biggest. And we actually just last Tuesday within our Quality and Safety Board had an analysis of what sits under communication, and the top theme is around our healthcare staff impact on patients. So what you're saying, regrettably today, is an experience that lots of other people have within the health board. I think what you've put up here is really incredibly helpful, and it's great to hear that you're now forming part of the paediatric listening group within the directorate. That's great. And certainly, if it's okay with you, we have a patient experience forum across the health board. So many members of different care groups externally as well to the health board will come in, and we work through what can we do to ensure that the experience is better. Now we know actually through the work we've done from a communication perspective that our impact on patients is the biggest theme. If it's okay with you, Joe, we could use your recorder or in fact yourself in person just to come to talk through the wider patient experience group where we have clinicians that sit on that group as well. Because there's nothing more impactful, is it, Joe, when you listen to somebody that's gone through a lived experience. So thanks again for being so brave to come and talk to us today. And you know, pretty much I know the board will have really listened to what you've said, and we will definitely take forward some of the things that we've got on the screen. So thank you again.
Okay. Yeah, Joe, good morning. Getting views on which she's operating on. So yeah, just reiterate sharing such a difficult story, and you know it's really challenging to hear. And I guess there's, you know, sitting here reflecting and you know what Greg's just said, there's something really I want everyone in the health board to know Elijah's name, and I want every member of staff within the health board to be able to reflect, because I'm sat here thinking, yes, it is about how our clinical staff respond, but actually it could have been a porter, it could have been a domestic, it could have been any member of staff, and I think, you know, we all work in healthcare, we all have a responsibility. We all have contacts with families, and it's really difficult, isn't it, when you're walking around the hospital, you've got no idea what's happened to that individual, whether they've just had marvellous news, horrible news, feeling very, very vulnerable. You know, but we live in hospitals. We know, you know, it is, they're horrible, scary, vulnerable places, and I think we have to commit actually to the board that every member of staff in CTM knows about Elijah, and that Elijah's name will trigger a reflection, and that's what we can do to help, because I think, you know, it's as Paul said, it's never intentional, but it is so powerful, and you know, that has to be our collective commitment. That we all know Elijah, and what a beautiful picture. That needs to be with all of us.
Thank you, Bertie. Any other comments or questions? I think Gethin's comments about how we can take your story forward, take Elijah's story forward, how your experiences can help us as a board to improve what it is that we do and how we do it, I think is really important. And go back to Greg's points around how we support and engage our staff around, you know, what appropriate and sensitive communication looks like, and the realization that sometimes even when you're not intentioning, there's no intention to offend somebody or to cause upset, that somehow sadly the easiest or straightforward slip can cause, you know, immense heartache and distress. And I think it is, you know, worth us reflecting, and those points that are listed on that slide I think are really, really important for us to think about how we take that forward collectively as a board with our staff. But Joe, thank you ever so much. I can only imagine the pain and the distress, not only losing your son, but being in that situation where you felt that, you know, your instinct was being ignored, that your pain was being overlooked by staff who didn't understand why you were so upset and so concerned. I think that, yeah, these very real, very tragic examples are very important to us as a board, for us to learn about what it is that we do and how our healthcare system can be far better at what it does. And our healthcare system in many ways is phenomenal. We have so many talented and amazing people who save lives, fix people up, get them back on their feet. Not always the case. And with organisations like ours, sometimes, you know, things don't work out in the way that they simply should. But it's important for us to learn and to change. And I really appreciate the bravery you've demonstrated in coming here today, but also the way in which you've engaged with our staff and our groups in supporting them. And I'm so pleased that this can be shared as well in that Wales-wide network for others to understand, you know, the consequences of what happens when, yeah, when we fall flat. So thank you very much for being with us today, and all the very best from all of us. Thank you. Thank you. Thank you. Thank you. Thank you. Okay, we're going to take a 10-minute break. Okay, it might be a bit longer if you need it. Okay, but I'm not rushing. Can I say Claire is sorry, Claire, Moving on to item 6 of our agenda, the chair's report. I don't have anything to add to the report. Much of it is covered in the discussion we have further on in the agenda. There was just one item, well, two actually, in respect of the use of the common seal, 2 items listed under 3.1 of my report. I'm happy to answer any questions if colleagues have any. No, okay, fine. We'll note the chair's report. Thank you very much. Just moving on to the action log. Since our last meeting at the end of May, there are those items that are in progress. Can I just check with the exec team, just to double check to see whether there's anything that needs to be added into this? Are there any updates on the update? Those matters still in progress. Okay, thank you. Any questions on the action log? No? Colleagues happy to note. Thank you very much. Chief Exec's reports. Thank you, Paul.
Thanks, Chair. So a few things just to draw out, just to update, as you'll see in the report, the most recent communication from Welsh Government around our escalation status. So you'll see there's been no change following the most recent escalation meeting. We've got a copy of the letter from Welsh Government confirming that. I'm going to say we are making good progress in the performance areas, as you'll know. We'll get in touch later on, and hopefully the escalation around performance may be reviewed again when the tripartite meeting meets. I think it's November time now will be the next opportunity to review that. Also, just wanted to update on obviously further what's going on with the ACSP. As you know, we've got a program of work that's being developed now to sort of think about the pre-engagement phase of our process, and that is being led by Linda, obviously, through her and her team, and also based on some of the feedback which colleagues were involved in from the Consultation Institute about how we best conduct that. So that work is ongoing, and I'm sure we'll have further update at the September board about the next stage of that development. Just also want to say, and I might comment on this, that there's been a proposal from the directors of Therapies and Health Sciences to rename themselves to reflect the fact that many of the professions for which Lauren is responsible are not actually therapists, they are classed as allied health professions. So the peer group of all of the executive directors of Therapies and Health Sciences have looked at whether they could be renamed as Director of Allied Health Professions and Health Sciences. So I just want to bring that here. That's been confirmed by a couple of other health boards already, and it feels like it's a more up-to-date reflection of the role as it is today. So that's something we will move to adopt as our organisation moving forward. Also, I've included here now. I don't know if it's come out in yours. I'm on my PDF. The exec priorities template hasn't actually come out that well. Have we got? Is it okay on the admin controlled version?
It's not okay, well, it wasn't okay in admin, but it's okay on the.
Oh, okay, on the bundle, right? Okay. So what we've tried to do for you here, and also for our own purposes, is to pull together the key strategic things as a exec team we're focused on over the next year. And partly to give you an overview of all the things that are in train, but also to enable us to, or for yourselves to be able to check in with us as and when needed on where things are against the trajectory that we've planned for the next 12 months. And I think what you see from that template is there's a lot going on, and there's a lot of work happening in a vast array of different areas. But I welcome any feedback. I'm conscious we've not done this before, so if you've got any particular feedback, or if it's too detailed, not enough detail, please do let us know, and we'll try and make sure that it's useful. What I would perhaps propose is that we bring back on a sort of quarterly basis that report, so that you can keep track on where we are against those programs of work. Obviously, that will also tally with things like the Board Assurance Framework, the Risk Register, about our ability to deliver against some of those things, because there are dependencies, as you can imagine. So hopefully that is of use to you. And then the only other item I just wanted to raise with you, which isn't in my report because it's only just happened in the past couple of weeks, is you'll remember we had a conversation in the board a couple of months ago as part of an All Wales proposal around the emergency air ambulance service. and the proposal to change the basis of the emergency air ambulance service, which was agreed by what was then EASC and then the new Joint Commissioning Committee. It's just to let you know that we have received a letter before action for judicial review from members of the public in Powys who are seeking to JR on that decision. There's a bit of a conversation going on at the moment because obviously as the host of the JCC, the probability is it will be CTM that will be the receiver of that action on behalf of the other health boards, but there is a conversation going on about it because the other parties' lawyers think that it should be all 7 health boards that are the respondents. So there's been a conversation going on between our lawyers and their lawyers about who is the actual respondent. But suffice to say, there is the initial action being put forward. Now we are responding with the JCC to that through legal risk, as who are acting as our solicitors, and clearly we will keep you updated as that process develops. But I just wanted you to be aware that it's quite current, only happened in the past 10 days. So in case you see any news about that, I just wanted to make sure you're up to speed, and we will keep you informed. So that's all that I wanted to raise, John.
Thank you, Paul. Any questions to Paul on his report? Kath?
Yeah, thank you, Paul. Yeah, really good to see the work plan. I was just going to emphasise, I guess, the primary and community care transformation programme feels a little bit lost. I know you put it under exec directors, but is there any chance of being able to pull that out a bit more, bearing in mind the importance of?
Yeah, so I think there's 2 parts of that. I think there's the primary care, you know, building on some of the conversation we had this morning around what the future model of primary care is. So I think there's a big piece of work. We've got a session in the next couple of weeks with the primary care team to talk about what is our strategy for primary care across CTM. And then there's that broader, I guess, link to ACSP really about how do we start to develop sort of out of hospital services to try and move away from our reliance on hospital being the only answer to every problem, and trying to develop more services local to people's communities, building on our primary and community care infrastructure. But yeah, we can certainly look at how that's described more here. Because I think, to be honest, it's probably the number one thing we need to be focusing on as part of our future strategy if we're going to really, really serious about shifting care outwards.
The board notes report. Thank you very much indeed. Item 7, our governance risk and assurance item. If I can move to 7.1, our board, committee and advisory group highlight reports. And the first one is our digital and data committee report. Ian, can you just provide a quick update on the data and the matters of fire escalation? I know we've got a report further on in the agenda.
Yeah, that's right. A lot of what I would say is coming up later. So I'll just highlight a few things to point out to people. And the first one was we had a detailed discussion in the last meeting about national IT programs, and we went into some detail about those. People will be aware of the concerns relating to national IT programs, one thing that came out in particular for us in the meeting was the way that the business cases were put together and proposed at a national level within those programs. And the fact that they were treated as standalone projects rather than things that were continuing. So effectively what happens is the business cases get put in and there's no sort of ongoing funding related to them, particularly at health board level. So staffing, things like that and wherever. And so we're really concerned with this process that seems to be going on continually with national IT projects and has led to financial issues with them and has also caused an issue with them being late or not happening at all in a lot of cases. And that has caused a problem for a lot of health boards, and for ours as well. We see this later, so the discussion will come up later on that. But we felt we needed to alert that to the health board. I'm sure most people are aware of it, that we felt that needs to be alerted. It is a national problem. It's not just for us. It's a whole national problem. Welsh Government's aware of it as well, by the way. I know that from a meeting I attended last week. Anyway, I won't go into that in detail. The other point that I just wanted to highlight was just to note really that the JCC digital and data arrangements are still being finalised, obviously because it's a new body, so that process is ongoing. So I just wanted people to be aware of that. The other things you can see there, so I'll leave the report at that point.
Thanks, Ian. Any questions to Ian on the update report? So we're covering off most
Yeah,
of
we'll
those.
pick it
Pick
up
up
later.
the report later. Okay, great. Okay, thank you. The board resolves to note the report. Thank you very much. Next item is the update from the Quality and Safety Committee. Karen, over to you. Thank you.
Thank you. You've got the report there for information. That's from our May meeting. I wondered if I could just highlight a few issues from
Great.
Tuesday's meeting, as we've had a more recent one. You'll see that on the report you've got boarding is under the alert escalate section. And on Tuesday, because this is of such concern to the committee, we had a presentation which involved a video of a patient's experience of being boarded. And this patient also happens to be an employee of CTM. And we also got to hear from the clinical staff's perspective how that experience was. And it was really, really impactful and very distressing actually to watch. So I just wanted to make people aware of that. It is something we agreed to highlight to the board. We have to think, I think, about the role of the committee in what we do about this. It was very tempting to just say, can we never ever board anyone again, because this is awful. But obviously we understand it's a whole system issue. We understand it's about the level of risk and where the patient is safest, but clearly really distressing. And we want to encourage, we're obviously aware of all the work that's going on with that. We also took a report on stroke services, which remain very fragile, and there was a significant amount of concern around that, although we appreciate lots is happening to try and improve that. We noted the quality improvement programme for mental health and learning disability and the excellent work going on there, and also HIW's acceptance of TVDR action plan, and that the actions on there are pretty much completed. So there were some really good areas of practice there. For advice, we noted the continued challenge and importance of balancing clinical capacity and financial controls. And there was a debate about the constant difficulty of quality of care, financial risk, and we just need to make sure that balance doesn't tip. And so obviously with the role of the committee, we've got an eye to quality. We were assured about a new contract to maintain the data on population segmentation, around which have been a number of issues with people pulling out of contracts or contracts ended. So there was some assurance around that, and also around the issue of backlog maintenance and the fact that those issues are being prioritised using a quality and risk focus. And for information, we were notified of the new head of IPC being appointed, which was very welcome news. So happy to take any questions on that, but as the meeting only happened this week, that's just
yeah. Thank you, Carolyn. That's really helpful. Any questions to Carolyn on the update? Okay, thank you very much. Thank you for the update on the. Oh, sorry, Linda. Hi. Apologies, Linda.
Hello. No problem at all. Good morning, everybody. Carolyn, I'd really be interested in that video. I wondered if you might be able to send that video around. And I guess just it's one of the things we're talking about all the time now in the NHS. That boarding has become completely the norm everywhere now. It's not just an exceptional thing. It's happening. It's the middle of summer and we've got boarders right, left and centre. So I'd be really interested in that video if that was possible to send around. Thank you.
Yeah, I'm sure we can circulate that to the board, can't we? Yeah, we'll take that as an action, Linda. Thank you.
Thank you, Linda. Much appreciated. Okay, so the board notes the report. Thank you, Carolyn. Item 7.1.3, the Population Health Partnerships Committee. Again, Carolyn, many thanks.
Oh, that's me again. Okay, again, the report is there for information. You'll note that under Alert and Escalate, we continue to discuss the issues around rising childhood obesity, and we know the decisions that we've taken as a board in terms of what we invest in and what we don't. But just wanted to escalate that as an area of significant concern and to encourage the ongoing discussion about how we might address some of those gaps in service, but recognising the financial issues. Happy to take questions on the rest of the report.
Thank you, Carolyn. Any questions on the update report? No? Okay, thank you. We'll note the report. Moving on to the Stakeholder Reference Group Pilot Report. Anne, thank you.
Yes, just to note, we are trying to extend the membership and representation on the stakeholder reference, particularly around representation of protected characteristics. So we've had a nomination come through from the Secretary of the Racial Equality Network. So the SRG approved that membership, so we should just follow the board to approve it today.
Any questions? Okay, thank you for the update. We'll note the report. Thank you very much indeed. Thanks. Item 7.1.5, the hosted bodies audit and risk. committee. I'm going to ask Gareth to provide members with an update on the previous meeting.
Yeah, thanks, John. Yeah, it's just to remind the board really is that we use the hosted bodies board and risk committee as our way of providing assurance to ourselves and the other health boards around the internal arrangement as at the JCC as we're the host. So I brought this here today because in June that was the first opportunity we had since the initial meeting of the JCC, just to give the assurance that all the legacy statements from risk and from each the predecessor joint committees had gone through the appropriate due process and governance arrangements. And also we've got some assurance that they are now developing a risk framework, which is the equivalent of our board assurance framework. And I'll continue to work with colleagues at the JCC. And just to add, Chair, as well, they've also appointed a transition director with my immediate predecessor here at CTM, George, who some of the many on the board will already know very well, and I'm also working closely with her just to ensure that the appropriate governance and accountability arrangements are in place going forward. Obviously, provide further updates at that for board meetings. Thanks, John.
Thank you, Gareth. Okay, any questions on the highlight report? Okay, thank you. We'll note the report. Item 7.2, escalation status update. This was covered in the Chief Exec's report, so I wasn't proposing to extend discussion on that any further. But again, it is something that is regularly discussed with Welsh Government ministers as with a new process now that's been put in place. Chairs of health boards that are in some form of escalated status, which is all of us, now have a quarterly meeting with the health minister on that aspect of the intervention around our escalated status and what we're doing to ensure progress. And that is in addition to the monthly meetings that we as health board chairs are having with the health minister around other areas of our performance, around plan care recovery and cancer care in particular. So just to flag that up with you, so there's a lot going on in this particular space. Okay, item 7.3 is our board assurance framework, and there are two documents in front of you, as a cover paper and a report, and I'll ask Gareth just to present the framework update.
Thanks, John. Yeah, again, a standard report which obviously we bring to each meeting of the board, and just a reminder that obviously the board assurance framework continues to be underpinned by our risk management framework and obviously the organisational risk register for which the audit risk committee look at all the risks and individual committees look at risks pertinent to them. So thank you as always to everyone involved in those risk updates and for the scrutiny that they get at those committees. In terms of standard updates this time around, you'll note in paragraph 3.3 we have separated out strategic risk 1 into two constituent parts around sufficient capacity to meet elective and then emergency demands. So they'll now appear as risks 1A and 1B respectively in the board assurance framework going forward. And then looking further ahead, there's scope to look at developing a further strategic risk around the capital estates, which obviously Sally is Executive Director of Finance is leading on, and Howell as our Director of People is looking at developing the leadership and management and culture and values and behaviours risks, looking at updating some of those. They've been slightly delayed, but that work will be ongoing just due to staff capacity at the moment. But again, you will get details of those updates in due course. And as John says, in the report itself, updates to the risks are in red text as usual. So we're looking for approval for the updates and the changes which are just outlined in section 3.
Okay. Yeah, just a quick question on the red updates. I don't know if it's like this on everyone's copy, but mine, some of the red has got lost out red text. Is that an old update? I know. I'll
just bring Cal in on that point. Cal?
Yeah, it's just so that we give you that assurance we're just not removing things. They'll be gone next time, so that's to show you what we're going to do.
Right. Okay.
And then where it's not strike through going in, so you've got that assurance that we're just not taking things out that we've put that back.
Thanks, Ian. Thank you, Kelly. Any questions to Gareth?
Yeah. It was around number 5 around digital and data, and I know we want to bring our risk scores down, but is 16 the right risk score, I suppose, or should it be increased? And I know I have to keep talking about it, but you know, the lack of systems, particularly around the mental health service. We don't even have whiteboards, electronic whiteboards. It's all paper files, etc. Do you know what I mean? And you know, and then after that update that Ian mentioned around what's happening with the national programmes, I'm just wondering is should we escalate that risk or not? So it was just a
No, I think it's a fair
question,
challenge,
really,
isn't it? You know, the digital landscape is challenged right now.
Yeah.
You're right to flag in terms of mental health, but also connecting care as a wider programme of work, which is not just about mental health. My understanding, just to cover that one off, in terms of where we are with the national business case, is a new version is being developed, due to be submitted into Welsh Government at the end of July. I know I'm probably going to, Ms. Mick will cover some of this now, so rather than make later, you know, I think we're going to do as a board. One of the actions we took over the last Digital and Data Committee was to do a bit of a deep dive specifically on some of these national business cases. That business case is quite extensive, it's a really comprehensive document, but it does ask for a substantial 8 to 10 years across Wales for community, primary and social care and mental health. So, you know, the chances of that being approved in the current climate are going to be challenged. As a health board, we are looking at other opportunities and aligning with other health boards more in a more still in a collaborative way, but perhaps on a more smaller scale, particularly for mental health. And this business case going to Welsh Government, specifically for BCU, that has been submitted, so that is backed, and we're looking to maybe partner with them depending on outcomes of some of that business case.
I think it's also recognising the local authority situation as well with social services and with their systems, which will impact upon us and discharges.
And just for the interest of clarity, so local authorities across Wales, aside from the CTM patch and the BCU patch, are going off procuring their own solutions at the moment. They're not the other thing of they'll be aligned to the national, but it's not part of it.
Just Lisa on this, Lisa.
Yeah, only that, the business case, I think there is discussion about splitting out the social care business case. So our business case and social care is going to go in separately. I think because we're at different stages.
Yeah.
So Contact Magana's got 3 or 4 health local authorities that are involved because they have joined us. We are up to tender as we speak. I think the closing date is August with the hope that we'll contract, I think November. Yeah. So they're quite tight timescale, but we've gone out nationally. Most of the local authorities have signed up for it. We've done it in 2. I think we are cohort 1 and North Wales and cohort 2. So we're out to tender.
They've had to do that because of the threats and the advanced termination of contract. Well, currently it's, well, I think there's an extension now, isn't there? But it was January 2026. I think they've extended it to 2027.
But what we in our licenses included, so the health staff, they're already on our licenses, yes. So particularly mental health, we've included them in our numbers so that when we we've got them already signed up.
Thanks. Okay, thanks. Okay, thanks, Gav. Really, so we'll come back to the broader.
It's a fair challenge on
data. You know, it is. I think in terms of the score, it's a fair challenge. I mean, we're going to take that away and have a look at it. Yeah. Okay. Thanks. Colleagues, happy to approve the update on the board assurance framework. Yep. Okay. Thank you very much. Approved. Moving on to item 8, delivering our plan. The first part is the integrated performance report. The exec team have decided to nominate 2 willing colleagues who will lead the entire item before we come to Sally's part on finance, and that will be Gethin and Greg. So Gethin, thank you. Over to you.
Yeah, thank you, Chair. So I'm conscious that much of the operational performance report has been scrutinised through PPF and the committee. So I'll just draw out a couple of key points for the board's attention. In terms of councillor performance, which we know is a significant high priority for us, for our patients, but also in terms of Welsh Government scrutiny, our performance was significantly improved in May at 56.5. I do just want to make the board aware that in June that figure will drop because we've had a very focused period of time addressing patients that have reached the 62-day target in neurology. We've done a significant focus in bringing the backlog volume down in neurology, and so that will trigger a drop in performance in June. Don't have that confirmed yet, but I just want to put that on board's attention. So we will see some volatility in our as we bring. The important metric there is, if you look, our number of over 104-day patients continues to reduce, and that's because of that targeted focus on bringing that cohort down. In terms of CAMS, again, we've got really good continued performance in part 1 and part 2. Part 1B, we've seen a real step up, which has been the one metric that's been in delay, and that's gone up to 76.3%, and that level is going to be continued. So really positive, and actually most government now have dropped, whilst we're still technically in targeted intervention for CAMS, they've now dropped that back to just through our monitoring through our IQPD, not through our targeted intervention meeting, which is positive and testament to the work really of our CAMS service. Diagnostics, there has been some movement. So we've seen a real reduction in our MRI numbers with the mobile scanner working at LHP. Our non-obstetric ultrasound numbers have gone up. That's been driven 2 reasons. One was the cessation of PAR, which was the payment mechanism for a period of time, and has also, with some staff sickness as well within our sonographers, the additional work that we were doing up to the cessation of PAR has been reinstated, and so that is working. And this weekend will be the first weekend we start additional cardiac investigations. So we're running weekend lists at both Prince Charles and Royal Glamorgan, again targeted on bringing that cohort down. So we remain on track with our diagnostic plans for compliance by year end. RTT, we do remain on track to deliver our 0 patients waiting over 156 weeks. It's really sad that we're still talking about patients waiting that length of time. Within CTM now, we've got the lowest cohort of those patients in Wales, and as I say, we will be at 0 by the end of August, which is a big commitment of reducing our cohorts. We have got then a number of interventions happening across specialties to address both the 52-week and 104-week challenge. And under unscheduled care, as has already been touched on by Linda, it still feels like January. Both in terms of the volumes of patients, the acuity of patients, and also the level of infection control challenges that we're seeing. The level of norovirus this summer is at a level I've never experienced, and is also providing significant operational pressure as we appropriately manage those patients. What is interesting is, if you look at the 15-minute handovers, we have got some of the better performance in Wales. It's still woefully low, but in terms of that focus of getting those patients off in a very timely way, our focus now is really reducing the volume of patients who take over an hour to be handed over, which is challenged. Link then to that and the discussion we just had on boarding, you'll notice that our patients experiencing delays leaving hospital remain high. We are an outlier in Wales with the volume of those per head of population, and there is now a target for health boards and local authorities to achieve a 10% reduction this side of Christmas, to reduce that, which has been mandated by the Cabinet Secretary. We will come on to some of the actions that we're taking to address that later on the agenda. And I guess the other thing, I know Patsy's not here, but she's often raised the question of our index rate for bowel screening. So we have seen a big improvement in our compliance with the 4-week standard for screening patients who've been referred under bowel screening. There will be again some volatility because we've had some sickness in one of the consultants who does a lot of our work. But we are working with Public Health Wales to increase the number of approved endoscopists to manage those lists, because for a screening patient only accredited, you can't be done by anyone. You have to you have to be scoped by someone who is deemed to be accredited through their programme. So that would provide a significant constraint. But they were the key points I wanted to draw out from the operation report.
Thanks, Kev. Greg, open to you next. Let me see your question. Just a couple of things to pick up from an IP&C perspective. So we've seen a slight uptick in C. difficile infections. So these are infections in the bowel compared to this time last year. Although you'll note in the report that we're still under the Welsh average, and just 30% of these infections are hospital onset infections. So obviously 70% within the community, which is challenging them, specifically if these patients aren't under any of our community services. Although patients that are developing these infections within our sites, there are minimal numbers of cross-contamination. So we do send the specimens for typing. So that gives us some reassurance that, we're not passing this infection on to too many patients. And one of the challenges in relation to C. difficile is overuse of antibiotic therapy, which can cause C. difficile. And very recently, there's been some more pharmacy capacity from an antimicrobial stewardship perspective to support our C. difficile work. So that's really encouraging to see that we've got some more pharmacy support. We have seen, so members that were on the board last year, we had a concern around rises in E. coli. We have seen a continued reduction in E. coli bacteremias this year. There's been a big focus on catheter care. So, and again, around 30% of E. coli infections are patients within our onset within our sites, which when we drill down in terms of some of the root cause analyses, it had been related to catheter care. So we've seen a 28% drop compared to this time last year, which is really encouraging. So lots of work still focusing on maintenance of catheter care as opposed to insertion, which was a concern last year. Although we've still got some work to do on line care, so peripheral lines and central lines, specifically around our high care areas. All that said, through some of the audits we've seen over the last couple of months, there's been some lapse in some areas on general IP&C precautions. So hand washing, fair below the elbow. We talked about this just on Tuesday within Quality and Safety Committee, and effective use of PPE. So we have a new head of nursing for IP&C started just a couple of weeks ago. So we are reviewing some of our audit work and ensuring that we try and be better at challenging in the moment. So if we see an opportunity for a hand wash and it doesn't get taken, or the 5 moments aren't all 5 moments, then we need to be better at empowering our staff to challenge in the moment. So a big focus piece of work on kind of going back to the fundamental IP&C practices. And I guess finally then, it's really good to see our continued drop in formal complaints. We talked earlier when Joe was telling their story, we've done an analysis of the top themes, and communication is the one. And I think we've seen a significant drop for 2 reasons. The first reason, we're better at ensuring that inquiries in the moment are dealt with at ward level. And we have introduced our PALS service probably about 6 months now. And so we have 2 PALS officers on each site, acute site, 1 in the community sites. So they're there to support the nursing staff and patients if there is an inquiry that happens that needs to be dealt with there and then. And that's it from my section. Thanks, Chair.
Thank you, Greg. Okay, any questions to get in or to Greg?
Not really a question, just building on what Greg was saying about the IP&C. Really, so we started to use our corporate comms channels to start kind of sharing some of those reminders about what's important to do. And I'm meeting with Philippe on Monday to start putting in place a little bit of a mini kind of campaign internally as well, which I hope will kind of maybe run for the next kind of 5-6 months as well as we kind of head into the darker and greyer days of winter as well.
Thanks, Simon. Ian, very quick question. I think it's quick anyway. On the RTT page, you're talking about ophthalmology. It refers there, referring patients to Spa Medica. I'm not familiar with what is Spa Medica.
So Spa Medica is a private provider of cataract surgery. They have a facility in Swansea. We used them directly last year as a health board for additional capacity. They are now being part of the regional capacity plan as alongside the Vanguard Theatre in Cardiff.
Thanks. Thanks, Kath.
Yeah, I've recently been around some of our learning disability services, and which sort of led to the question of where do we as IMs have oversight around those commissioned services, because obviously we don't provide them directly. And I'm just wondering if that's something we could think about what, what comes to board around our mission and long-term agreement, really, and how we have, a high level oversight around those services to give us assurance.
Yeah, we can pick that up.
Thank you. That'd be great. Thank you.
Thanks. Yes, sorry, Lisa. Yeah.
Right, so 2 questions on the report. For adult mental health, target 80% for those within less than 26 weeks of the therapies they have.
Yeah.
Our attention 54%. We fifth in Wales, do we look at learning from other health boards to see what they're doing different to us?
Yes, yes, no, we know we've been, and Andrew Davis, who's the lead psychologist, has been doing that, and we completely reconfigured our workforce. We've recruited, we've changed the workforce. We had a very traditional, purely qualified highly banded psychology model. That's now changed. We've got a tiered approach. We're offering additional other access to other services as part of that. It is just at the moment having enough capacity, but now we're constantly sharing with partners, and have been offering a whole raft of waiting list initiatives and outsourcing as well to try and get those waits down. They are improving, and certainly I think this is May data when we're looking, it is creeping up, but it's just not at the level that we would need.
And for children and families, so the NED, ADHD, and this, I mean, that's 30% in May, and the target's 80%, so that's quite concerning. I have to say that's not just a Morgana there was a news story this morning, it's the national Wales issue. I mean, I just comment really, I mean, huge growth in referrals, 510 to 2,589. It's like a huge difference. So the demand on services,
we've been having the conversation with Welsh Government on this, because it's an all Wales problem and UK wide problem. Part of the piece we need to do is work with education, because I think there is a raft of patients that are referred in for assessment in order to access support. Clearly, the process is very long, laborious, and we need to find a different way of working in partnership between ND services and education to make sure that we're targeting the right patients, so we're not delaying some children who just need some additional support getting it through a long process, but those that clinically need input into that service are getting it in a more timely way.
Linda.
I just picking that up quickly. So there is a whole program of work around the advice, as you know, and I could give you some headlines from it, but it might be more sensible for me not to do that, but to actually bring a report through that talks about how we're reworking access to ND services and the impact of that. We're hoping that the improvements we hope that makes for families and for access to services.
Thanks, Linda. Gethin, I just want to place on record my thanks to Gethin and the team. I mentioned earlier that health board chairs have been having a monthly performance review with the health minister, and the current health minister, who by next week will be the new first minister, has had a very strong focus on eradicating the long waits. So really focusing on addressing why it is some people will be waiting a long period of time for treatment. Gethin and the team have really stepped up to that. Okay, it's put a lot of pressure on the system. Chairs have been under pressure, so chief execs. But Gethin and the team have worked incredibly hard in order to bring those numbers down. Gethin mentioned earlier the drive to reducing delayed transfers of care, rather than the numbers in the system, by 10%. The health minister last week did say 15%, so we may want to double check whether it's 10 or 20 next, but it may be 20 next week. But no, there is a fear that we are facing such a challenge in the capacity of our system now, but once we do get to the winter period, it will become simply unbearable. So, and I understand why government is very keen that we drive that. We'll come back to that afterwards with the plan and the approach that Gethin and the team again have been pulling forward in terms of what we're going to do about it, but it does require a concerted effort on our part. COVID in hospital, the numbers of patients who were being tested for COVID, where are we with the numbers at the moment? I was down at the Princess of Wales Hospital with Greg a couple of weeks ago and talking to Sarah, your deputy. I think at that point she said we had 50 people in POW with COVID. I'm just wondering what the numbers were looking like. We've heard about a COVID spike in the summer. I'm just wondering, is there anything you could just confirm on
I know in POW on Tuesday we're up to 62 patients, which causes significant challenges with trying to ensure that we isolate those patients that are early into the infection, and then obviously ensure that the unscheduled care pathway is maintained as best we can. So the teams do their very best to risk assess every day with the IP and C team in relation to whether we close a ward or close a bay or cohort patients. Of course, that's coupled with some norovirus that we have around and still some respiratory infection. So it is really tricky. The easiest thing to do would be to close the ward as soon as we have an outbreak, an entire ward as soon as we have an outbreak of COVID-19, as we did back in the day, for 8 to 10 days. Of course, what that will do then is cause significant disruption to the urgent care system. So there is dynamic risk assessments happening daily to make sure that we balance the risk between limiting a nosocomial spread for ensuring that the patients at the front door, have a hospital bed to come into. It's really tricky.
Is there any pressure in terms of staff with COVID?
Not to my knowledge.
Quite a lot of staff were
No.
So it's not amongst staff so much.
Well, I mean, just to echo what you said about performance, I mean, actually, we should be pleased with seeing the really systemic, improvement that we're seeing on the long waiters. I guess the other bit which we need to look at is the number of referrals we're seeing, and again, it's across Wales, it's a picture here, and I just reflect back to the primary care conversation, because some of this is how we work with primary care, because I've got absolutely no evidence for this, but you could have a hypothesis, couldn't you, that if primary care is massively under pressure and they've got the time to deal with people appropriately, the easiest thing to do is refer people on. And so I think we've got health pathways, which is the new sort of process by which we're trying to sort of design what's the optimal pathway for someone to go from a GP to a clinician in hospital. Have we made sure we've done all the alternative options for that individual before they go into it? But I think once we've got to the place where our long waiters are beginning to sort of see the sort of shoots of improvement, we've almost got to go back to the front of the queue almost as well and say, how do we stop those people how do we stop creating more of the problem by having more people coming in? There's some quite binary assessments being touted by Welsh Government about how we can create more capacity to see more outpatients. My question, I suppose, is do we even need to see them in the first place, or could we actually be diverting them at source away from the hospital? Because I think my worry is we keep pouring more and more and more into the tank, but and because we're emptying the tank at the bottom, we're putting more people in the top. So I guess we just, and I know Gethin's got this in hand, and the health pathways will help with that. But I suppose we just got to keep an eye on the outpatient first appointments growth. That is at risk, otherwise we're all just chasing our tail.
Thanks. Gethin, looking back.
Just very briefly, so Paul's touched on health pathways. That's a model that's been developed in Cardiff very effectively at providing a really good interface between secondary care and primary care. So there are clear pathways, there are clear criteria, there are clear investigations and other tests that general practice need to do before referring in. There's then a triaging process for those referrals, which will help. Equally, we know so for CTM, we've seen the biggest bounce back in referrals post-COVID. So we're running at 130% pre-COVID. No other health board has got back to 100%. So we are an outlier in terms of the demand that we're seeing from general practice. But equally, we know our service models aren't quite right either. So coming back to Lisa's challenge earlier of how are we learning, we've done a lot of work with Cardiff. So just there as an example, they've completely transformed their tonsillectomy pathway, which we are adopting with pride, which is a nurse-led process. There's very clear criteria now as to whether or not you're suitable for a tonsillectomy. We've got thousands of patients on our waiting list for first outpatient in ENT for tonsil. The vast majority of those patients will not meet criteria. So at the moment, they wait 2 years to come and see an ENT surgeon to be told you don't need a tonsillectomy. The model in Cardiff is a nurse-led model. It's a telephone call. It's a very clear criteria-led service. They're seeing those patients within a week to 10 days virtually from referral, and the vast majority of those patients are not suitable for going on for surgery, and so they're managing it in a very different way. So we're adopting that requirement to say and rolling that out across the whole raft of our services.
Just to add to that, so I think first thing about going on as part of the Central Health Park design to look at our community diagnostic hub and how we use it, who we use it for. Because some of these referrals are because communities don't have access to diagnostics, and so if we can do more appropriate direct test, then that will also help. So we could perhaps look at how we extend that conversation for the here and now.
Just very quickly, sorry, I'm coming back to a point that Paul made about primary care and the impact of people accessing or not being able to access primary care. So I'm not sure if anybody, looking at Simon in particular, if you've received the published guidance that came out from the Older People's Commissioner yesterday, informing, I suppose, guiding older people in particular to their rights to GP service. I mean, it applies to everybody, but her target audience is older people. And when I read it yesterday, I raised my eyebrows at some of the things that I should be expecting from my GP that isn't actually happening. Things about data clock, ringing in data clock, and then all the appointments going within 10 minutes, and then that's it. You can't get an appointment for the rest of the day. You have to ring back at 8 o'clock every morning. And all. Now, from my understanding, that shouldn't be happening now. And certainly opportunities for e-consultation in some practices are not as available. They were fantastic during COVID, and some practices have stopped those and haven't reinstated them. So it does, I guess, loop back to the top of the meeting and the primary care conversation about what does primary care actually look like, and are our primary care partners delivering in the best possible way so that we do relieve some of the pressure and that people don't feel like the only option they have is to go to A&E or to access, care in a different healthcare in a different way. So I just wanted to check if you haven't had that. I can circulate it.
We have had that, Rachel. Last time, Natasha and Simon's team to send that Rachel all the practices have all had a copy of that, and we also do some promotion of that from our own organisation. I think we've got a catch up in a couple of weeks' time around this topic of primary care with Gethin and Sarah Bradley and David Miller and others. I think perhaps what we could do is perhaps use a future some board time to perhaps invite David and Sarah and others to come and we can play back some of the thinking that's coming out of that session, because I think, candidly, Gethin and I were part of a session a few weeks ago, weren't we, Gethin, with the national primary care team in Welsh Government about this. Quite honestly, we've got to do something different, because trying to think we could just incrementally tweak the existing model, we're never going to solve it, because it's falling down around, and it's not just a Wales issue, it's a UK-wide problem, and it needs a complete rethink, and that's going to be quite challenging, both with primary care, because it requires primary care to work in a very, very different way. There's the contracting mechanisms by which we contract with GPs, and then there's the public expectation about everything. I want to see a doctor for everything, and so there's quite a massive piece. So if we're serious about that topic, I think we've got to give some really careful thought to how we as a health board are going to start sort of put our markers down about where we want to go in the future with primary care.
I think that'd be really useful. I'd like to make sure we include community pharmacy as well, because when we did the last board development session on primary care, we focused principally on the GP contractors and dental. We didn't include community pharmacy, and I think we need to ensure that we are utilising, going back to conversations getting around what we were doing around capacity in Kilmarnock as a bull. Where was the pharmacist? What could we utilise there? And I think community pharmacy is fundamentally important. Gethin, do you want to come back on the
just to provide assurance that that document has been circulated to general practice throughout CTM? That was action.
Philip, just to respond to Greg's points in terms of obviously there is a new nursing lead for IPC. We've also onboarded the new consultant for health protection within the public health team. We recruited to the principal role as well, and we're recruiting seniors and practitioners into that space. Obviously, that covers not only response to outbreaks of disease, but critically also preparedness and prevention, which is the most important thing. Just flag that up, as well as the eradication programs around hepatitis, HIV, TB, etc. I'm pleased to say that next week we've got the system-wide. We're finalising the system-wide health protection strategy with partners, including local authority partners, third sector, etc., which the IPC, the nurse will be attending, because that distinction between what happens out in the community and what happens in hospital is largely artificial, because once it's out there, it's in here and vice versa. So we're going to do this.
Thanks. I had one question left for Gethin. Sorry, Gethin, just come back to you again. In terms of the performance report, if I look at the target that we want to reach by the end of March next year, which is that nobody is waiting more than 52 weeks for first outpatient appointment. There's a very exacting, demanding trajectory that's been set. And as of today, I think we're adrift at around 4,800 patients. So we're going about a minute.
Yeah.
I was wondering the cause of that and how we are seeking to address it to try and bring it as close to back on track as we possibly can. I know it's a tough one. So we've got 15,000 or 20?
Yeah. So there's a couple of drivers to that, Chair. So the first is the trajectory we developed was a straight line trajectory, because the level of sensitivity to build in for each scheme was in the timescale we had to turn it around was a little problematic. So the first is we've got a straight line trajectory, not a trajectory of plan. So we do have those, but we don't have them. We don't report that in that way. The second piece is that a couple of the programs that we've got have been slightly delayed in coming on, which have been corrected. And the third bit, which is the important bit, is we've now just signed off for the vast majority of specialties. We have an allocation of funds within our planned care recovery programme for waiting list initiatives. We've just signed that off now for a number of those specialties, and those clinics are now commencing, and that will allow us then we'll start to see that sustained reduction in the outpatient activity. There is a risk at the moment, just to be clear with board, there is some risk within anaesthetic cover for some theatre sessions that we're working through at the moment. So that's an ongoing conversation with our anaesthetists around rates of pay. But that's being managed with Dom and Sally.
Thanks, really. Okay. Any further questions from colleagues? No? Okay. If we're happy to note the report, thank you very much indeed. Very grateful to Gethin and to Greg for presenting information this morning. If we move on to item 8.2, this is the month 3 finance update from Sally. Thank you, Sally.
Hi everyone, apologies for not being there in person, but I have managed to rupture my Achilles, so hence can't drive anywhere. So stuck in a chair with my foot up at the moment in the world's largest boot. But to go on to the finance report, in terms of the position at month 2, you'll remember I flagged some real concerns about us being off track. Month 3 was marginally improved, but still a deficit of 0.4 million in month. So our year-to-date position is a 2.7 million deficit. Within that, the main driver is a 4.8 million shortfall in savings compared to a straight line target, and plus adverse operating variances of a further 1 million. Cost pressures have been offset by 3.1 million of other improvements to bring us to that net position. So we're continuing to forecast a break-even position, which is our planned position for the year, which is so it's consistent with the plan, but there are some significant risks against that. So the key risks are set out on page 18 and amount to 9.2 million, and the main risk is the delivery of the 26.3 savings target. In terms of our recurrent position, we've chosen at this point to focus on our in-year position and ask teams to work up their underlying position as we move into month 4 and month 5, with a detailed review of the forecast to be undertaken at month 6. So currently we're showing we're still showing a planned recurrent surplus at the end of 24-25 of 2.1 million. You'll remember that's what allows us to start thinking about how we plan into next year and how we have further flexibility available for investments and meeting cost pressures. However, as it's currently off plan, we do need to recover the position and the recurrent position in order to enable that to happen. Other than that, I just wanted to draw your attention to the table which is at page 8 of the report, which really gives us our, in terms of our forecast, what do we need to do to land that break-even position, and why are we able, with the current deficit, to maintain a forecast break-even position. And what this shows you in some detail then is the savings shortfall and the other operating variances within the forecast, which amount to 18 million. Then a sort of offset from our non-delegated budgets, which allow us to, which total 14.3 million, which means the absolute minimum by which further savings are required to achieve break even is 3.7. And in addition to that, we need to manage those risks of 9.2, which are set out on page 18. So just to sort of give you a feel for where we are, there is a need for us to take action to bring that expenditure back in and to ensure that we're delivering the savings by an absolute minimum of 3.7 million. Happy to take any questions.
Thank you, Sally. Before I open it up, can I just ask 2 very, very quick points? In the report, you referenced the way in which some of that additional cost has been offset by improvements in our contract and commissioning and through reductions in agency staff. I'm just wondering in terms of how that was achieved. Is there something specific that was done to achieve that, or whether it was just a consequence of where we were in our sort of planning?
So we set aside money for agency inflation, which we're now judging that we do not need to apply. So that was set aside in the plan. There is a risk we will still see that increase, but we are trying to manage that. And within contracting commissioning, that's a series of where we ended up with the various long-term agreement arrangements and with our colleagues where we provide services outside. There is some risk to that, so it's probably worth me flagging to the board at this point that we were unable for the 2nd year running to agree a position with the Nyren Bevan Health Board, and we are as a consequence in arbitration again around the level. Significant compromises were offered to AB as part of that process, but we were unable to finalise the agreement. So we're awaiting feedback from Welsh Government colleagues about their view on that arbitration.
Thank you, Sally. Any questions to Sally on the finance report? Colleagues happy? We'll note the report. Thank you, Sally, much appreciated. And hope you're on the mend, and very nasty injury to sustain, and hopefully you'll be fighting fit as soon as possible.
Thank you.
Okay, we'll move on to, we're going to just juggle things around a little bit because we've got a team of people joining us for the development of our plan to address delayed transfers of care. So what I'm going to do is ask them to come in now, if that's. Sorry, Stuart was ready.
I tell you what,
Stuart was ready to go.
It's now being built up beyond all.
Stuart was perched on the end of his seat, ready to pounce into his item on developing our approach on digital and data. However, as a team are eagerly waiting outside, if we want to drag them in, we'll move on to, we'll juggle it around a bit, and we'll come to Gethin's item.
No.
Okay, I'm going to hand over to Gethin to introduce this item. We've got some colleagues of ours. Gethin, you can do the introductions, I think. Can I also welcome back Adam. Adam, of course, came to our previous board meeting where we had a very powerful story about the experience of gentlemen who've been waiting, well, who've been with us for an incredible length of time. And it was after that discussion, having gone through a whole series of conversations around the challenges of supporting patients to be able to leave a hospital and to go either home or into a different environment, that we decided that action was needed, and Paul convened a team. I know Adam supported that work, and Gethin really now is I know with our colleagues here, motored on with this. The Health Minister was very, very clear with all health boards that this wasn't just about trying to identify the reasons why somebody was stuck in hospital, but where perhaps from the point of view of the NHS, we could be doing more to support people to safely leave hospital where they were able to, and to go home with some level of support to facilitate their reablement, getting people back on their feet. That challenge was put to us. I said to the Health Minister last week that having put that challenge to us as health boards, we would respond, and we are responding. So, and this is the report back on where Gethin and the team got to with that plan. So Geth, over to you. Thank you very much.
Lovely. Thank you very much. And I'll quickly introduce the team. So Lucy Williams, who's Director of Nursing for Community and Primary Care, Paula Cornelius, who's our Head of Occupational Therapy, Julia Wilkinson, who is Director and Manager for Community Services, Adam Cook-Young, who is Advanced Clinical Practitioner in Frailty at Princess of Wales, and Guy Griffiths, who leads the Community Health and Wellbeing team in RCT. So this is these guys have been working very closely with me and others to develop this model. And I guess, you know, if you go to the next slide, please. Next slide. So we heard the story of Bern, and we were all exceptionally moved by his experience. This was a gentleman who was admitted to Princess of Wales, was medically optimised, clinically optimised by day 20, and sadly died in Princess of Wales at day 162, and had multiple opportunities to get him home. But we weren't, as a system, able to do that. And equally, we know, and we've had the presentation in the same board meeting about the fact that our admissions have gone down. The number of patients that we're treating on a 0-day length of stay has increased, but we know the bed days we consume has gone up, and that has been driven primarily by the cohort of patients that stay over 29 days within our hospital. And we know the impact of that. You know, we know it has a massive impact on our patients with high levels of deconditioning. We know that that has a big impact on our acute patients because we can't get them through the hospital more quickly. And we know the experience for many of our patients, as we heard Quality and Safety Committee, about the impact of boarding has. So we know this is just not it's just a really inappropriate way of us managing this pathway. And so we asked ourselves the question, and I think we asked ourselves the question of, as a health board, what could we be doing differently? This isn't social care's problem. You know, we have a role to play in this, and it is really important that we recognise what could we do differently to support these patients, and particularly looking at those patients who are on what we call a pathway 1, who are patients who are going home for a package of care, because in reality, many of those patients won't need a long-term package. Even more of them will go out needing a package at this level, but actually their long-term need will be much lower. And so what we're ending up doing is we're over-prescribing, and then patients go out with that level of package, and it's really, really difficult then to bring that package down. So we're actually making the pressure on the social care service more difficult. And so our principal aim was, how do we develop, using a chunk of resource we've got now, recognising we're going to have to invest in capacity, support to get that 100 patients who are waiting to go home, but actually also recognise that we admit a lot of people who don't need to be admitted. There is no medical reason for them to come in. They have to come in because actually we can't provide we can't respond to their social care crisis whilst they've perhaps got a small infection. And so it's really important that we look at how we get people home more quickly, but actually how we stop people coming in when they don't need to come into hospital. That's where we've got to. I'm going to ask the team now to run through. If as you want slides to move, just ask Tyler to move the slides on. It's terribly Chris Whitty, and then I'll ask you to take us through the proposal.
So our staff, thank you, Gethin. Thanks to put that into context. The next slide, Tyler. So we are delighted to come here and speak to you today about a lot of the work that we've been doing, not only with this service, but across CTM as a whole, to improve our flow and discharge processes. It's the wicked issue of health and social care, I think, about how we are dealing with an ageing population, what is our approach to frailty, and really taking in the evidence that unless you're acutely unwell, actually being in hospital can be quite bad for you. You can think of the deconditioning, the loneliness, the isolation, also that feeling of not being in control of your own life, and also not being in control of your own discharge. We've done a lot of work with partners. I'm looking to Lisa and Rachel. We're working with the third sector, with local authorities to really create a service that is doing the right thing for patients, to pull them out of hospital as quickly as possible. And as Gethin said, try and avoid them going in unless absolutely necessary. So we've got a programme called the Optimise programme that is really focusing on that, as well as the implementation of a new discharge pathway, which is national good practice called Discharge to Recover, then Assess. So we're saying that we have more patients in hospital who are optimised to leave, but actually what we're saying is we need to optimise them earlier, because actually where people recover and get better is at home. We need to medically treat them and allow them to recover in the best place for them. So the model that we've created as a suggestion for this team, it's not our idea. I'd like to say that it's our invention, but it's not. It's taking all of the good practice and the evidence that's been in place since the year 2000, when they put in nice guidelines around intermediate care and how intermediate care should work. So intermediate care is fundamentally that gap in between secondary care and primary care. What are we doing in the middle for an enhanced level of care that pulls people out of hospital quickly and stops them going in? And in Wales recently, there's been a lot of work done under the strategic programme for primary care, looking at that enhanced level, especially of intermediate care, and saying what it could look like in Wales. So we can see there we have 4 levels of enhanced community care. And what we are saying fundamentally is we've already got services in the community that are focused on discharge. We've got great reablement services within the local authority. We have got therapy services in the community. We are not going to duplicate those. We need to support those to do work well. But if people are waiting for those services, pathway 1 on a reablement, if we keep them in hospital, we would say that patient is in crisis because of the environment and the harm that could provide for that patient in terms of deconditioning. So what we are saying is we need to focus on enhanced community care level 4, and that is defined as a crisis response service for patients to avoid them going into hospital and to pull them out quickly. And there are time standards that we would need to respond within 2 hours of a multidisciplinary team to deliver that crisis response service. And when you map how this is being delivered across Wales, it does look like, and it is backed up, that ECC level 4, so enhanced community care level 4, is usually a health-led service. So it's delivered by registrants, but actually what you need within that, because another term for that is hospital at home, or a virtual ward. And when you think about what we do on the ward, we not only give them nursing care, therapy care, care from a doctor, we also provide basic care for people. So helps with their activities of daily living, helping them with their food and that kind of thing. So actually within that virtual ward, we need our registrants, but also vitally we need carers within that system. So Tyler, if we could go to the next slide. So within primary and community services, we're saying there are 3 key priorities that we have to deliver to pull people out of hospital quickly and stop them going in. And the first is, as I mentioned, the optimised programme, which is reducing time in hospital. That is our fundamental priority. We need to reduce length of stay, increase discharges, and we need to make sure that happens at the back door. So that's the integrated discharge team, as well as the front door to make sure that we discharge appropriately before we even admit somebody. And that is coordinated through our navigation hub. Our navigation hub is a clinical navigation hub, which is triaged by GPs and registrants to make sure that we're providing the right care for the patient. And then the navigation hub can link patients to the right services in the community. Those are the services that we've already got, and what we are saying is that fundamentally we need to deliver a virtual ward which is defined as enhanced community care level 4. So if we go on to the next slide, Tyler. So our priority is to pull together our community services, because at the moment they're quite fragmented. They do great work, but actually if we had a great mass of staff, they'd be able to deliver this virtual ward in the community. We've got evidence of silo working between professionals. We need to pull all of those professionals together and think about the care we're providing for our patients. And what we've done is we've mapped resources across the community services, and we've actually got a lot of resources. What we need to do is we need to use them better, we need to use them smarter, and we need to think about the outcomes that we're delivering for those patients. However, when we've mapped those services, what is missing from those services is that care staff. Because, as I said, you cannot deliver those services without the fundamentals of the right care for patients in the community. So go on to the next slide. What's really important to us is to understand our demand and capacity. What we'll go through in more detail our demand from hospital. I think, as everybody knows, as part of the optimised programme, we've done fantastic work developing electronic whiteboards at ward level, where we know the day that somebody is clinically optimised, and also what is the next step they need to progress their discharge journey. We've put in new roles such as trusted assessors and new process, being very clear that we know when that patient is ready to go on the right day. So we've got all of that data around discharge. What's harder to quantify is avoiding admissions, because you don't know what you don't know, actually. But what we do know is that graph there gives us some indication of conveyances. So that would mean patients who are attended by an ambulance in CTM and who are taken into hospital. And we can see the yellow line is CTM, that we are the highest for conveyances for patients associated with frailty. So those are frailty markers. So that would be conveyances associated with fall and conveyances of patients over a frailty score of 6. So we know responding to frailty appropriately is what we need to do. And we also know on any one day how many patients are waiting to be discharged from hospital on a pathway 1. Thanks, Tyler. As we go to the next slide, I'm going to hand over to Paula now that's going through the service.
Thank you. So we reviewed information that we had on the electronic whiteboard and found when we did the audit on the June the 18th, that we had 314 patients across our inpatient services who were clinically optimised. Obviously very concerning, people that could and should be at home. We then reviewed the data on the electronic whiteboard and found a number of opportunities for discharge had been missed, which was potentially escalating the care needs and causing sort of deconditioning amongst that cohort of patients. We reviewed who was on pathway 1 out of those 314 patients and found that it came to 139 patients. So patients that only needed a short period, hopefully of intermediate care or reablement intervention to optimise their independence at home, which would normally be obviously in the local authority integrated services up to 6 weeks in duration. We audited that again and found that 80% of those people could be managed at home with a care package of a maximum of 3 calls per day. There was some overprescribing, obviously clinicians assessing people in hospital, assess on the basis of what they see, and very often, as we all know, when people go home back in their own home environment, feeling comfortable with family members around, they don't need the level of support that we've said they need. So we worked out that we would need a service that could offer up to between 80 and 100 patients care from a healthcare perspective, and obviously not just the care side of things, but the health elements that service could offer as well. Slide, please. Next slide, please, Tyler. Thank you. With some support from Guy, who we found out is an excellent mathematician, we worked out that we needed around 240 care calls a day for those 80 to 100 people, which equated to 1,680 calls a week. And we worked out, according to population size, what that would look like in Merthyr, RCT and Bridgend, and you can see the figures there. We feel the service should very much mirror what we've got in our integrated services. So it should run from the hours of 7 AM to 10 o'clock at night, covering all sort of aspects of that individual's functional independence, and also providing therapy intervention, calling it a bit of therapy light, because it isn't to replace what we've got in our local authorities and integrated services. This is to enhance and support the discharges, and then ultimately support people in the community preventing admissions. And we worked out that each carer would have approximately 5 calls a day, depending on the complexity of what was required by that individual. Next slide, please. And here you can see what that kind of added up to in terms of care calls a week, care calls a day, number of staff members required on shift. And we worked out, in order to deliver a 7-day service over that time period, we would need approximately 85 care staff. And we discussed what the care staff role would be. It would be enhanced in the sense of that care staff member might also have some basic nursing skill set that they would have on a ward. And they would also have the ability to deliver a therapy-led intervention plan. So that person would have competencies in both areas. Next slide, please. And there you can see we feel there's a need to create a health team in line with the NICE guidelines, which would be multi-professional, time limited, and support people in crisis because they're stuck in hospital in phase 1, and ultimately phase 2 we were looking at preventing people from actually coming to us in the first place. You'll be aware that we've got our SWAR teams and some work going on around our front door services. We've also got investment we've had in therapies, and we've got additional resource sitting in our navigation hub preventing admission, so we want to build on some of that. The team would be built up with a core team of registrants and support staff, largely support staff, the site of registrants, and obviously we need management staff involved in the mix there as well. And from our perspectives, our objectives and our positive outcomes would be that we'd be providing the care in the right place, targeted at people who would otherwise be stuck in hospital, and also be admitted unnecessarily for multiple reasons, including social breakdown, and it would obviously add to length of stay. We would also be looking at enhancing reducing the risk of hospital-based harm. We would have a focus of maximising independence. So the goal would be obviously to reduce that care requirement to the point where they don't need anything at all from our local authority services, or where we've right-sized that package of care. So when we do pass that back to the local authority, it's the right amount of care required, and we're not wasting resource. and obviously it would be time limited with regular stringent reviews. So if people, and having managed a community resource service myself, when people don't need the care, not waiting for the 6-week period to decide that they don't need it, regularly reviewing every week to check that they don't need the care, or we could reduce the care package. Over to Lucy.
Okay, can I have the next slide, please, Diana? Okay, so what we then done as a team, we looked at what our current resource that we had in place. So the first slide is our RCT and Merthyr resource. This is one of our community teams, and it's broken down in terms of job roles and full-time equivalents. We acknowledge and appreciate we need to reconfigure these before we move forward and have a look how they can work to align to the new service going forward. So as you can see, there is a wealth of resource that is also doing really good roles right now, and we need to make sure that as well as taking on the new roles, we believe these team will, that we don't take away anything from a service that it currently offers. Can I have the next slide, please, Tyler? This slide is our Bridgend locality. So even though we merged in 2019, we still have a separation between the services that we thought is going forward. We will pull all this together. We will manage as one service to have this whole ECC team right across the communities and across CTM to provide one service for our patients and our population. But it just broke down into details. Again, the full-time equivalent and the staff may have at the top. It's a much smaller team, but again, we would ensure there's parity right across CTM from the one team that would deliver the service. Next slide, please. Okay, thank you. So from us as a team, there was recommendations, obviously, to deliver the service. One, as I just touched upon, we need to make sure that we have one service that delivers the care across. Our patients down in Porthcawl should have the same service delivery for the ones up in Dowlais, and we need to ensure that's cascaded out through the teams. We've just touched upon is the ACT team down in Bridgend that would form, this is part of our integrated service at the moment, but it would form part of our wider ACC service. We were very clear on one of the slides that Paul had touched upon, once we broke down into health population and we broke down into full-time equivalents, we would deliver the care on a locality footprint as well, because that would ensure there was comparison and comparity, but also it would ensure for our workers and for our carers that they're in a much more geographical location to be able to provide that care. We would align our carers to the cluster base and our community teams for that out of our support and that additional support that they might need. And also we would ensure that there'd be no missed care calls. So we would have a backup service in place to pick anything up. The next slide, please, Tyler. Okay, and obviously as a team, we've discussed and shared with you, I guess, the background to where we're at, the positivities and the feedback, but also we have looked at what the risks and the challenges could pose with providing this services. Some of the risks we've identified is, we appreciate Paul has touched upon, we need 85 members of staff. We do acknowledge that could take and destabilise some of the dom care services that are out there provided. That is an acknowledgement by us. We want to, and getting touched upon it, we really do need to look at admission avoidance, not just discharge. We really need to shift the focus, and this team would be part of doing that. We've also had to look at our workforce gaps, and we need to look at our other community services. So whilst we've just touched upon some teams, this is almost phase one, I'd like to call it. We've touched upon some teams and I provided the job titles and the full-time equivalents there, but how we would align it to our district nursing, our community nursing specialist services, that is a plan for further down the line with us. And again, you know, Julia touched upon it, it is when these patients are in crisis, being in hospital when they shouldn't be is almost a crisis. We will cause harm to these patients and how we can support them and bring them out, provide them with the care they need, but also rehabilitate them at the same time. And that hybrid role work, we undertake that. Our challenges. Well, as I touched upon, some of our full-time equivalents and the roles we might not need within this team and we might need to reconfigure. So we would definitely need to engage with people services and take our teams to OCP. So me, it's very much around how we sell this new work and how, you know, the benefits for the patients, but also for the carers in that team as well. But we would do that through the OCP process. And it's also listening to our teams, you know, they are out there delivering these services in the community. It's how we can get them on board and how we can ensure we're doing the right things, but not just for the patients, but for our teams as well and our staff. So we identified some of the risks and challenges. I'm sure that when we start moving forward, there will be more as we move along. But yeah, that's basically we wanted to bring them forward to you as the board. I'm just going to take you back to Getty now to talk over next steps, if that's okay.
Thank you. If you go to the next slide, please, Tyler. Thank you. So clearly, we want to work on this at pace. We recognise the current pressures. And we've touched on the risk around the dom care market, and we're very cognizant of that, and clearly this will only work if capacity in the dom care market remains. So we need to be very clear about not undermining the core of the domiciliary care market. The other key aspect for this is funding for those 85 roles. So because we're not sitting, as we've heard in the finance report, with a large surplus to draw down on this. So this will be about rebalancing the capacity in our acute general hospitals, and that will release the funds for that. So the first priority is to complete the business case now over the course of the next 3 to 4 weeks. Clearly we'll go through exec scrutiny as ELG, but what we're asking is then to take that to PPF, and I guess an endorsement from board for PPF to have delegated authority to consider that business case. Part of the other piece of work that's sitting alongside that, so this is all concurrent streams, is that development of that clinical staffing model, and the training competencies and the need as part of that is there would need to be a mobilisation period prior to a go live, recognising there are a set of competencies that we would have to train staff on over and above providing personal care. And sitting alongside that, as Lucy's alluded to, is the OCP process for changing the existing teams, and that again will need to run in parallel to all of these pieces of work. Otherwise, the sequential timetable would push us to the right side of Christmas, and really we want to be mobilising this by end of October, really at the latest, to ensure that we've got the capacity going into winter. And the other key bit then is the practical piece around the operating model, and making that work in that way. We've been working, and I know, Julia, you went to the commissioning group with local authority colleagues and have been having some of those conversations. This is absolutely about working in partnership with local authority colleagues. It's not, and this is genuinely, we see this as our response to expanding capacity within the community. We're not suggesting at all we're going into the delivery of long-term domiciliary care. That's not our business. Our business is to support our patients and to get them as optimised as we can to hand them over with the least need that we can manage. And so it's a really important piece of this service, which is to optimise those patients to their highest level of function. Because genuinely we believe that probably around 20% of the patients we currently refer won't need any service beyond this, and that probably around 80% of those that we will manage through this service will need a lower ongoing care package than currently we're prescribing through the discharge arrangement. So it was really to bring this update to get that endorsement of the model and the principles, and the recognition really that we will be trying to progress this at pace.
Thanks, Kevin. Paul, thank you. Well, yeah, I mean, just hopefully board members will see this is almost quite a nice sort of closing the circle from when Adam came a few months ago to describe the challenges that he experienced looking after his patient at Prince of Wales Hospital. And I suppose one of the things we did as a consequence of that board meeting was, and which is great to see, is the product of this has been a collective heads together of lots of different people from lots of different areas. So Adam and colleagues working more acute end of things, Lucy and other colleagues, and Julia and others who work in the community side. We've had nursing, we've had district nursing, we've had therapies, we've had GPs, we've had care of the elderly consultants. We had a couple of task group meetings where actually everybody came together to say, well, what could we do differently? And actually what was really interesting was there's some really quick wins actually also, even just about connecting people together, saying, well, actually, if we need, district nursing, well, if we knew which of our patients were in the hospital, we could actually make sure that we were talking to the ward nurses to say, well, we can manage that at home, don't worry about that. So there's a lot of benefit, and I think it shows in such a big organisation with so many different bits. Sometimes we get lost and actually by bringing everyone together, suddenly, hey, presto, people will come up with a solution that is really sensible and I think will make a big impact. I'm really pleased that we're developing this. I absolutely agree with Gethin. This is really go into this with very wide and open eyes of we don't want to destabilise the domiciliary care market. I was talking to Paul Me yesterday at RCT about this. I think there's something about maybe as we start to develop a competency framework for these roles, how do we talk to the existing domiciliary care agencies? Because actually there may be something here we could offer to the dom care agencies to say, well, here's a training package that we could offer to some of your workers so that actually for the people who do need ongoing care, it can be done with under a sort of a re-ablement ethos, which I think might also start to skill up some of our dom care agencies, perhaps provides a bit of a career pathway through, and we can start to talk about, you know, come in and start work as a dom care worker for a couple of years, acquire the competencies and maybe move through into a professional qualified role down the line. So I think I hope that we can start to do this in a way that is done in tandem with social care colleagues, which is what you guys have already described. I think fundamentally the most important thing is though people who receive this care are enabled to get back home as quickly as they can. And I guess my question was going to be back to Adam. You know, if Verdon had this sort of service available to him in Bridgend when you were caring for him, would that have meant that we could have got him home quicker and enabled him to have had perhaps a better outcome than the? Because I think, you know, this came out of the conversations we had at board back along about that particular patient. So I'm just interested to get your perspective, having been involved in these conversations.
So I was given the opportunity to be Verdon's voice back in March when I presented to everyone. So I'll speak on his behalf and say absolutely yes on day 5 and another opportunity on day 20. But as there's an excellent SFAR, and it's clearly demonstrated to me the need for this, the need to think differently, the need to take responsibility as health providers for health and some elements of the social care, because the patient doesn't care who's going to do it. They just want to make sure that they have that safety net. And when they're at that crisis level, that they have the support that they need. But as has been clearly demonstrated here, 20% may be able to be downstreamed from it and not need the care till the end. Think of the flip coin of the patients that are currently sat in our wards that are going from needing care, packages of care, to deconditioning to needing nursing care. So it's a flip coin of benefits for both ends. So I personally really grateful and find it a very positive movement. And from what I'm hearing on the wards, we want to see real action for our patients. And I think as people have come into health services, we're here because we care about people. We care about our communities. We're part of that communities. Our elderly loved ones, some of us will be elderly and will need these care. And frailty is it's going to become a bigger issue, not a smaller one. So we have to be thinking like this to make sure that the patients coming in the next wave are getting the care that Verdon should have had at the time. So, yeah, thank you.
Thanks. So, okay, I've got a list of people who want to come in at this point. I'll start with Geraint. Thank you.
Thank you. Just before COVID, a couple of years before COVID, our health minister called Vaughan Gething, you remember, health minister called Vaughan Gething, launched a transformation fund of £50 million. I think it was over 2 years, if you remember. And one of the joint bids, I think, from the CONTAV, as it was then, local development, regional partnership board, and I'm looking at Lisa Curtis Jones now, was for a project which had some of the themes which would chime very much with what's been said here. I think that these are all things which we should all be in favour of, and more joint working. We've had parliamentary reviews, we've had lots of reports done about how this type of work should be enhanced. 4 words I haven't heard in this report: stay well at home. How is that? Does that still exist?
Yes.
And how does it complement, fit in with what's been done here?
I'll bring it in.
Thank you very much.
So that £50 million, our share of it is what's funded.
This is what's
the team, the teams, the existing teams, that those teams, I think it was either Lucy or this slide showed, that money we're using for that, it's not enough.
Yeah, we've now got to embed.
And stay well. That is the stay well at home. So that
yes.
yes.
and they decide to have it. So Stay Well at Home is still very much a service, the
Right.
front door service, and it's an admission avoidance service. We've touched upon, we appreciate that admission avoidance got to come in. I guess we've started small or smaller, if that's the best way to say it, as phase one, before we look at pulling everything in. But yeah, that is still very much a proactive service.
That's what I also say, there were two elements for Stay Well at Home, if you remember, and that's what came in the transformation fund. So the old ICF, the original legacy funding, was SWA, Stay Well at Home at the front door.
Page 1.
Yeah, and then we extended it to transformation for SWA 2, which was about admission avoidance and the community health and wellbeing teams.
Pharmacists.
Yes, so I was just about to mention that. It also supported Your Meds at Home, which was an intermediate care service for the community that pulled people out of hospital. The slide that Lucy showed included all elements of Stay Well at Home 2, Shoot Community Health and Wellbeing Team, as well as Your Meds at Home. Because in the slide where we said we've got good services, but they're fragmented, what we're saying is all of those services need to be pulled together. And the SWA 1 resource was the thing about the integrated front door. So absolutely right, it's all those resources pulled into one pathway.
Thank you.
Ian. Yeah, totally supportive of this. I think it's a great initiative. One potential risk, as I see it, and so with pointing out, obviously we put patients now into their homes that would have been in a hospital ward, and in the hospital ward they would have had access to a nurse by pressing a buzzer or whatever. Is there a need for them to have maybe some sort of hotline when they're at home if there's an emergency? And if that's the case, with some people who are not technology enabled, we may even have to loan them mobile phones in order for them to be able to phone our hotline. I just see it as a risk because we send them at home and they could potentially be at high risk.
So I guess what we need to remember though, these are patients that have now been deemed ready to release.
Yeah,
and so technically they should be at home.
Yeah,
they're clearly, and I'll let Paul in, but there should be, and there will be, methods by which they can contact. And of course, we will be having multiple contacts with them during the course of the day anyway.
Sorry, just repeating a bit of what Gaston said anyway. These people would be medically optimised. So if there was capacity in the traditional service to take them out, they would just gone. They will be going home. They will be having a review by a registrant therapist. They will be having their daily 3 calls a day, potentially depending on need, from a healthcare support worker. If they are known to the district nurse team for whatever, because these people still have chronic healthcare conditions. Just because they don't need to be in hospital doesn't mean that they don't have chronic healthcare conditions. So we still have the access to the district nurses, obviously the person's GP, etc. And then, so phase 1, ultimately, as Gethin has alluded to, we'd like to bring in and sort of work on the medical model and have, really do develop that hospital at home element. But initially, they would be, supported by the services that we already have. Actually, it's more enhanced because if you go home with an intermediate package of care, you don't have a registered therapist come in to visit you. You go home and you would see a care team member, and that would be it. Apart from if you did have some DA. So
let's add to that as well. I really agree with you that technology is really important as well. So we definitely just work with local authorities about Lifeline. So Lifelines are a really valuable service. And if somebody does have a crisis, they go straight through to the Lifeline. In RCT, they've got a pick-up service. We'll work with the local authorities around the Lifeline so that if there is a crisis, the Lifeline service is absolutely fundamental to delivering the care of this population group as well. And we regularly will put in a Lifeline to facilitate discharge so somebody has rapid access to help.
Great. Yeah, thanks on that point. Just on the Lifeline, there was some a rather exciting sort of futuristic technology, which is not so futuristic now, where you could monitor literally with sensory pads and all of that, and that people could be watched. I mean, is that being looked at
local
again?
Authority, I think you can speak around that. Local authority or regularly deliver a care package.
And it's been updated the next couple of months.
We might try. We're talking about limitations that have multiple and complex comorbidity.
Yeah.
We're never going to be able to eliminate this with the patients. think we have to talk about mitigating and managing as best we can. But the risk of remaining in hospital for somebody that is not will outweigh the risk of being, yes, definitely what's written in evidence.
Thanks. Karen.
Yeah, very, very quickly, most of my points have been covered. It's fantastic to see such a practical response to a really difficult story. The only thing I would add is the evaluation of this service needs to be built in right from the beginning so that we can very clearly demonstrate the added value.
Yeah. Lisa, and then Linda on the TV.
From a social care point of view, ethos behind it, we can't disagree with it. I mean, really positive piece of work, and it's great to see it sort of come into fruition, and this is going to take off. There have been lengthy discussions with social care colleagues, and I guess I'm going to say, but there is a but. The risk around the staffing, I don't think we can, minimise that. It's a major risk for us because potentially we'll end up losing a lot of our dom care workers because you may pay better, it's better prospects, and therefore I worry about that 6-week period. You get patients home, best option for them and good outcomes. But is there then going to be that's where the blockage is going to be then at that 6 weeks rather than being in hospital because we can't take that package on because we haven't got staff. And I know that's been raised in other forums, so I know that's which I'm going to pick it. But I think going back to Paul's point, I think it's really key that we have that conversation about us working together around staffing, having a career pathway. We've got young people coming into the service who may work for us, but there's prospects for them to go on to have a more senior role, maybe even go into nursing further down the line. I think we've got to think about how we work that because I think that will have a positive impact on this piece of work because we're not against it, but I think that risk about the staffing needs to be considered.
I think that's really important, Lisa, because I think, candidly at the minute, as Greg was describing, when we advertise healthcare support worker role anywhere in community or acute, we get about 40 applicants for every job. Now, what would be quite useful to do a bit of work on is understand where are those people coming from, because some of them may well be, some may not be, some may be coming from other areas or be changing careers.
Predominantly are just really quickly. We had one applicant, we had one post in YCR, a 30-hour post, and we had 72 applications. So it's tremendous, a number of applications.
So the people are, and it'd be interesting, Lucy, to have a look at where those people are coming from.
Yeah, we have a variation. We have a few from other health boards, not many. Predominantly, I will say, a good 60% of that is already from some sort of care provision out there in the community. They already are.
I mean, for us, I speak from a perspective, a lot of our people work locally, so we may not lose. No. Our city project may be very different.
But the key thing is to think about how we might do this jointly and almost position it as part of a career pathway for people to stay.
I think a lot of happening around domiciliary care. Where we come from. Domiciliary care, a lot of people come from retail and want to work flexibly because of working hours to do with children. So I think around that progression, so we could really work together with social care. Well, I think there's also a career pathway around college, looking at young people. If nursing is an option, they consider it, but they couldn't go down the degree route. I think there's options for them that we need to consider as well.
Lisa, we could even revisit the Tony Garthwaite report on career structure for social care practitioners. You've been around as long as we have. You know what I'm talking about. Linda.
Yes, thank you. I'm completely in favour of this model. Having been immersed in community services for the last 18 months, just wanted to put out an offer there that there's loads of this stuff already happening in England and it's really well developed and everybody understands what the pros and cons are about it. So if anybody wants to pick any brains, then I'd be really happy to put people in touch with people. I also just wanted to say, don't underestimate the change. I mean, we've just done a big bit of work on a brand new service that we've offered. We've recruited 100 people. We didn't look in the domiciliary care market. We looked outside. So to Paul's point, trying to recruit new people. It's been brilliant, but it was tough at first, but we're getting there with it now. But and then just a final point to say was, this type of approach involves tipping the risk appetite completely on its head and as a healthcare provider taking more risks. That's what we've found, and that's been quite difficult culturally for members of staff. But if anybody would like to talk any more about this, then we could do it offline.
Thanks, Linda. That's incredibly helpful. Okay, I'll come to Helen and then to Dilys.
Yeah, just a quick one from me.
thank you to the team, really interesting and good to see your enthusiasm and good to see that something comes up at board and then it comes back to us in this positive way. So thank you to Gethin and Paul and everyone here who's spoken today. My question was to Gethin, really. You said, Gethin, I wrote this down. I tend to do that. We'll mobilise by October at the latest, and I just wondered, what's the risk around that in terms of getting people? I think that's been partly addressed.
There is a risk, clearly, and we have. It might be a phased mobilisation, but we have to start. We know, and we might choose to prioritise one area, but we know we have to. Hence why it's quite a tight timetable of getting the business case through and approved, so that we can start recruitment and onboarding. We are in discussion with Welsh Government to support some seed funding with this as well. But it is, the end of October, we have to start reducing the number of pathway 1 patients in our hospitals by the end of October.
And it sounds like people are not the problem. Getting people once the jobs are advertised are not a problem, although I recognise the knock-on potential problems there might be. But
that's why we need to absolutely do it.
I would certainly be in favour of doing whatever we can to streamline the process to bring people, into this environment. I mean, there must be dozens of people who applied for roles who would have been qualified, but just for whatever reason got picked to the post by somebody else. And if those people are there and they're still looking for these sorts of roles, then we need to find a way, quite frankly, of getting back in touch with them. And making that whole HR process.
Well, yes, I agree.
But there has to be a process, admittedly, but there needs to be. We need to look at that.
But we should also miss the opportunity, I think, to think about our role in terms of encouraging employment from some of our more deprived communities. There's something about perhaps going proactively out into some of our communities, using our community leaders network to say these opportunities are coming up. Do you know of people in your community that are looking for work, who might be interested in getting into this sort of world, maybe as a career pathway into something else? So I think there's something we can do from both ends of that spectrum.
I think, sorry, linking to that, if you link in with BAMT,
Yeah.
Barvo and Interlink, those people who volunteered during COVID and perhaps didn't get employment afterwards, you may make links there with people who would step up then into this role for volunteers. Sorry.
No, thanks, Liz, that's helpful. I'll come back to you in a minute, Rachel. Dilys and then Rachel.
Thank you. I'll be very quick, Chair. A lot of what I was going to say has been said. Getting mentioned about working in partnership. At another organisation I'm involved in, we had a presentation from RCT Council, who are currently developing the adult social care strategy. Maybe we're speaking to them, because one of the priorities that came across from them was to keep people at home. And they were talking about the technologies that Geraint referred to. Can I say I'm really pleased to see this at board today. Verdon's story really touched me, really got to me. One of the ones out of all the ones we've heard, and board really did get to me. And I'd just like to congratulate Lisa on the district nurse service. My husband's been using that for the past few weeks and they've been absolutely epic.
Oh, thank you very much.
I just wanted to say that.
Thank you.
Thanks for listening. Rachel.
Well, hopefully, finally, just to close the loop on everybody that needs to be involved in this. And you already mentioned that there are a number of different partners providing different levels of support in communities, in hospitals, and just to declare my interest, Age Connect Ghana, who I work for, is one of those partners. And we've talked about how local authorities and the health board can work together, but let's not forget the role of ongoing long-term support through volunteer activity that can actually help people stay happier at home and not just well and fed and bathed and dressed. There's a whole other form of support that keeps people's well-being really well maintained, and the third sector, I know, is really good at doing that. And so I guess from a risk point of view, if we're going to see many more people coming out of hospital, prevented going into hospital, and that whole wraparound service does involve non-statutory partners. Let's just make sure that we, as the third sector, taking one hat off, putting another one on, are involved and understand what that means, because there isn't an awful lot of funding around for volunteering of that type. And it requires a very certain type of volunteer that wants to do that kind of work. And, I certainly know of organisations that would bite your hand off to work with you and develop a volunteering offer. I'm sure Anne can speak more sort of clearly on this, being a member of Interlink, an employee there. But yeah, we're happy to talk and you know, help spin this up. Brilliant.
And it's a sector in terms of when someone is discharged, and they go through that package, it's about that prevention. So becoming lonely and isolated and the impact of that. That's where the sector, I know the social prescribers sit on the CHUP team, so that's quite good in that they can refer into the sector services that way. But it's that prevention, you like,
Yeah.
what you're out to. So.
And recognising the support of carers, you know, because there's carers in this mix as well, informal carers, and what can we do to make sure that they can manage while, you know, they are caring at home for somebody. That's a really, I think, a big issue that we could focus on.
Just to build on what Rachel said, we've got good strategic partnerships developing around discharge. Obviously, we've got Rachel's organisation supporting with those links into the third sector, links in the shoot team already. But really, I think carers especially, we're very cognizant of supporting that support for carers directly around discharge and doing a specific piece of work on that. So thanks for bringing that up, Rachel.
Thank you all very much. Look, the report contained a series of recommendations and a series of next steps. In front of me today was a suggestion that we would be sort of noting the work that's been done. I think we need to go a step further, and I would ask the board to give its support to the recommendations that are in the report that's come to us today, and support to the next steps the team are seeking to develop. I think, you know, it's important for us to get behind this work. We asked for this work to be done following Adam's presentation to us back in March. You know, we recognise that here was a challenge to us as a healthcare system to respond to. So I think we have to, it is very important. I would ask the board to approve what is in front of us today by way of an approach, recognising, of course, that there's a suggestion also that the business case will go to the next meeting of the Planning, Performance and Finance Committee, which is on the 27th of August. Can I ask for the board's permission to delegate the decision on the business case to the PPF committee on the 27th of August? I do not believe 1 second we can wait until the next board meeting, which is at the end of September. That's another month on top of that. We need to delegate this to the committee. I would also, I know Pat is not here, but I would also ask if other colleagues who are not on the committee who want to attend that meeting, please feel free to do so, at least to participate in the discussion on the business case. I think that would hopefully add some further weight to Gethin, and to get this absolutely nailed by the end of August, so that you can get on and focus on recruitment, focus on the systems, training, things that need to be in place fairly quickly. Yeah, colleagues happy with that as a course of action? Yeah, brilliant. Thank you all very much indeed for coming. Much appreciated.
Okay, thank you.
Right, we are going swiftly on to updates we have. I said Stuart was poised, waiting to pant, and he's going to a spotlight report on digital. It's an update on our strategic outline page for an integrated healthcare system. This is a huge plank of our strategic development. And Stu, over to you.
Yeah, well, thank you, Chair. So Carly did say to me that I had an hour and a half for this item.
Make it two.
What I was going to say is Philip put his watch in front of me. Lauren turned to me and she said, "Oh my God, I'm starving." And Greg said, "I think we should postpone the whole item." I've got the message.
It's good exec support.
Nothing like that, eh? No, but in all seriousness,
that's really important.
It is
as much time as we need.
It's fine. So the paper does set out in a lot of detail for you anyway, in terms of the case for change, the national picture. Clearly, there'll be significant financial considerations downstream for us to think about, and notwithstanding the technical issues that we will face. But if I can just pull out a couple of salient points, really, and take you back, actually, colleagues. We were in March, we did our board development session with a really thorough morning on where we are. And this is really the response to that in terms of the next steps for us. I've tried to be fairly balanced and make reference to the national programmes, but I am looking for support from the board today to move forward with our modular EPR strategy and actually go to the next phase of working up the procurement elements to look to procure a strategic partner. And to do that, clearly that would come back to board, because there are some significant investments that we would need to consider, both as a health board, but also given the level of investment that possibly required, we would need to get Welsh Government support on that as well. So just to be clear, I'm not asking you to commit to any money today, but actually just to commit to that process of moving forward with the procurement strategic part. As I say, the case for change, I think, is pretty much made. What I would say in all of the work that we're doing going forward, this is a fundamental building block, a key foundation if we're really serious about our acute services plan and also the wider health board strategy work. The reality is we won't be able to do that without any bit of this electronic solution. We've come to the conclusion of modular. That's really been based on a couple of things actually. Our capacity for change, though, in all of this, there's a huge amount going on already within the health board and the organisation. A modular approach does give us that opportunity to control that pace a little more, but also focus on perhaps some of our more particular pinch points. For example, at the moment, we know unscheduled care is a massive pressure across the health board. We know we need an ED solution. That could be the next stage. You know, we need to go through a process of assessment and decision making, but we know that is something that we would want to take forward. So that modular approach really does give us that opportunity to control in a far greater way. I think it would be remiss of us not to make reference to the national piece, given the conversation we had earlier. What I would say, actually, there's been quite a shift over the last 6 to 12 months in terms of national views. And most health boards now are talking about an EPR type approach going forward and what that looks like. It would be a significant move away from historic ways of delivering digital services in Wales and you know, looking to more perhaps off-the-shelf stroke commercial solutions, working in partnership with more in Wales developed solutions. But I genuinely feel the appetite is there, and certainly the work that we've done over the last 3 months, and actually all health boards have done, is a review of readiness of health boards to move to an EPR type, a modular EPR type arrangement going forward. So that has come back universally as the right way to go. I think closer to home, if we think about the region, we've certainly got consensus with our colleagues in AB and Cardiff on a modular approach to EPR to provide the solutions for the patients of South East Wales moving forward. And that does actually have touch points into Valentia and Powys as well. From a technical perspective, integration and the data layer is going to be key. So this is not about being locked into a solution where you can't get the data out. We're going to be really clear on that, but actually integration with our existing services and future services in a truly modular way will be fundamental to that. And I guess the last bit for me is just the, you know, the financial and the sort of service that we're taking. It is a significant ask. You know, there's some scary numbers, let's be blunt about it, in terms of what this could cost. A solution I would be looking, if we were to go down that route, would be to commit to us for a lengthy period of time, put in the paper a minimum of 5 years. This is probably a 10-year commitment, being really honest about it. If this would set us up for the next 10 years, it would be really, again, significant undertaking. And work has been done within BCU, which sort of talks in the region to manage expectation of around 5 to 8 million a year, and perhaps for BCU a little bit more actually. So that's the kind of, and that's a mixture of capital, but that is the kind of money we're talking about. So I think, you know, as I say, to be really clear from today, all I'm really asking the board is to really improve. So the next stage is really the development to that towards the cure cost. So
that's your Paul. Yeah, I mean, just to build on what Stu said, I mean, I think we talk a lot, don't we, about the opportunities that digital presents in terms of improving the way we deliver care to our patients, streamlining, making us more efficient, using data to help drive improvement, quality outcomes, better experience for our patients. But at the root of it, unless we've got a good patient record system, we're never going to be able to do all of those things, because at the moment we've got a hybrid of sort of a patchwork of different bits of solutions for different problems, many of which are quite outdated and not able to provide us with the level of information we want. And I think all of us in the executive team feel quite frustrated that we can't get good quality data. So, you know, when we're talking about things like the ACSP, we're saying well, let's get some data out on, you know, what's the current level of activity in these specialties, and well, it's not easy to do it. And then, you know, we've got clinicians that are working with very clunky systems, and frankly are operating despite the system, not because of it. And I think Stu and I and a few of our clinical teams went up to see our electronic prescribing suppliers solution in anger being deployed in Leicester. And they've built on that, and they've gone into a solution that now delivers ED, it delivers theatres, it's delivered a whole range of things. It was almost embarrassing for us to see how technology had really changed the way those clinicians were working. And what was fantastic was hearing clinicians who spoke really positively about the solution. And, you know, we've all been there over the years, many of us, and seen solutions deployed, and clinicians go, yeah, it was meant to do all these things, but it never, then it's actually a hindrance to us doing the right thing. These clinicians were actually really, really positive about the way that technology was enabling them to provide more timely care, better care to their patients, safer care, because it was providing all the right information about the individual there and then for them, but also more importantly had streamlined massively the way they ran their processes. So, you know, they not only were they able to sort of get back the right information, they were able to say, well, now we don't need to do all those things, we can take all those steps out of the equation. So this for me is a massive plank of our transformation journey, not just from a digital perspective, but as an organisation in terms of how we deliver care to our population. I think, as Stu's rightly said, there's a big price tag attached to it, but candidly, if you look at what's going on across the NHS, across the UK, everywhere, certainly in England, is procuring and buying commercial off-the-shelf solutions, many of which are big bang approaches. So I've done one of these deployments before where literally you push a button on one day and the whole hospital changes. We're not talking about that. We're talking about a more gradual incremental build, which I think is a lower, there's always risk, but it's a lower risk approach. And it all enables us to manage the change, because candidly, we are starting from quite a low base.
Yeah.
And we're going to have to do a lot of change management alongside the technical deployment, because this is going to be a very different way of working for many of our clinicians. But to be honest with you, if we don't do it, we're going to struggle to recruit new clinicians, because everyone's being trained in places where this stuff is now core day-to-day business. And if we don't provide that level of kit and infrastructure, people will say, well, I can go and work somewhere which is much more digitally advanced down the road, so I'm not going to come and work for you. So it's not just about the digital opportunity, it's also about making sure that we're fit for purpose for the future, and we can attract and retain the best staff that we want to have. So I would absolutely endorse it. And I think, as Stu said, this isn't about signing off to a big ticket price tag now. It's saying, is the board supportive of this approach towards a modular electronic patient record solution, and that we go out to the market to see who's out there and start those conversations with suppliers to see what they can offer and bring to the table, which will then inform a more detailed business case then moving forward.
So that's what Carolyn and then Ian. Thanks.
Just very quickly, I'm fully supportive of this. As you know, we've had it through Digital and Data Committee. I just want to note, I just feel that there's something really lacking in digital health and care Wales, that so much of this is having to be worked on within local health boards, and it's just appalling to me that, you know, you're having to go, well, so much is having to be done locally. There's a whole years of history of this, and I think it's really important that whatever we do is able to, as you say here, to talk to all the other systems, and we're not developing in isolation. That's really good to see, but I just do have concerns about where is Digital Healthcare Wales in all of this, but I'm fully supportive of it.
That's Carolyn. Ian.
Yeah, similarly, I'm totally supportive as well. I suppose if we go back, the grand vision, of course, was where we have all health boards in Wales buying into one big national system. But as you just alluded, we're not there, are we? I mean, they've been working on this for a long time now. We're at the situation whereby we need to provide a service for our local clinicians and for our local patients. And nationally, that doesn't seem to be happening. I talked a little, I alluded earlier on about some of the problems on national systems. I could talk about that for hours, but I won't do that. And I think in the absence of that national system, we need to provide those services for locally. So I think what Stuart is proposing is the way to go. And the modular approach is great as well, because you can do it in incremental bits. The only thing is, when Stuart mentioned this to me, the only thing I said that we need to do, and he's put it in the paper as well, is we need to maintain the validity of the data. Because eventually, I think we probably will have some big Welsh national system, but not quite yet. So the national data resource, of course, people will know, is where we keep that data which we define the structure of, rather than a third party. Because in the past, what we had big suppliers, I shouldn't name names, but big suppliers like Fujitsu and IBM, big companies like that, not them, but like that, coming in and defining data very, in a very specific proprietary way. And then when you eventually decide to go with somebody else, to try and disentangle that data became a nightmare. So if as long as that principle is there, we maintain the validity of the data in the NDR, then when we eventually move to other systems or go national, then that is still valid.
Thanks. We'll come back to that. I think Kath, and then Sally and Gath.
Yeah, I was just going to echo the same comments really, to say I don't think we can wait any longer. We've been waiting a long time to have this sort of national solution. And at some point, as a board, we need to say we've got to take action now. And I think it's sort of come to that. So I'm really supportive of the work you're doing.
Sally.
Yes, 100% supportive of this. I'm really pleased to see it moving on. It is eye-watering money, but I think it's really important to get the right system. Would rather having been through a similar experience where we were tempted into a cheaper system that didn't work so well, and the consequences of that. So getting it right, having full clinical engagement, which I know you've got, and I think the clinicians will all be fully behind this because they're begging for it themselves, actually.
Yeah, and I guess just picking up Sally's points about money, we spend an outrageous amount of money, really inefficient systems, processes, and workforce because we don't have such a system. And actually, this will allow us to transform the way in which we deliver service to our patients. It will allow our staff to work really differently. So I completely endorse the approach. I think the points Carolyn and Ian make are absolutely well made. So yeah.
And I will not labour this point, but I mean, we talk about individual patient record, but obviously in terms of aggregate opportunity because population not very much, right? We just think we get fast up there. And the NDR one day, hopefully. Yeah.
That's good. Just from my perspective, I know that there is pressure within the system to identify big national programmes to deliver for the entirety of the NHS. But history in Wales, I'm afraid, is littered with dreadful mistakes, colossal wastes of money, where national systems simply haven't delivered. They've become overly expensive, dreadfully bureaucratic, not done according to time, and have not delivered. And the world has moved on whilst those national conversations have taken place. The health minister made it very clear to all health board chairs in a meeting in March, and she said she wasn't bothered about us designing new stuff in Wales, just for Wales, when there were things out there, off-the-shelf commercial opportunities that we could strike to bring products into Wales that already existed, that already had a track record. I mean, for goodness sake, when you're spending public money, we talk about the waste that we've seen in this space in the years. We've got to get real, and she was very keen that we adopted that approach. Now, that makes it very difficult because there are relationships we have within the NHS where we have a national body that does work in this particular field. But for me, this is about how we as a healthcare system deliver for our population, for our clinicians, to improve the experiences that people have in the NHS in CTM, and how do we deliver as much as we can with our colleagues in an RMBEV and Cardiff and the Vale, because we're about to push on at pace the delivery of a regional diagnostic and treatment centre at Llantriston Health Park that will require digital solutions. We are looking at the future for our clinical services across the whole of South East Wales, as we articulated some of that vision in that regional clinical summit recently. So, this is where we get, I think, a significant boost in what we need to do. Voting on ourselves and working with an RMBF and Cardigan Vale to deliver. It's incumbent on us to do this, and we've got to get the money bit sorted, which requires other conversations. But I think this is a fantastic start. I really do. Yeah. Gary?
Yeah, just in order to deal with the many sort of sharp-suited young salesmen who will be sort of hanging around.
I did know, is that where people hang out?
Social services don't think. Who advises us independently?
So we have procurement advice, shared services procurement, so that's the national body. For
so we will have some
we will
idea.
And as Stu said, Betsy Cabral have done already quite a bit of work on thinking through their strategy around this, working with shared services around.
So they've taken a similar paper to their board, and we're actually probably catching them up now. Actually, they've done they've done more comprehensive testing of the system, if you like, last November, in Betsy in particular around clinical appetite as much as anything else, and come to this conclusion. So they're now actively trying to procure a partner as well.
Okay. There is advice there, Garen, to reassure you. There is advice from
because there's somebody who can.
Thanks. I need to go back to Sally. You've got your hand up. I'll come to you next. Thanks.
So just to sort of round back on some of the finance issues there, to remind people though, in terms of accessing sufficient capital for a scheme of this extent, we will require Welsh Government approval and support. We just need to work out our routes for achieving that, because it will be beyond the scope of our discretionary capital. There's no doubt about that, and we can't overspend that. And just to pick up on Geraint's point, the other issue, just to note, of course, is that any contract over £1 million requires ministerial approval, and even if it's gone through a procurement process, unless it's from a compliant framework. So there are other protections in place as well. That was just where I wanted to summarise that.
Thank you, sir.
Thank you, Sarah. That's very helpful. Thank you very much. Okay, Stuart's report is for approval. Can I ask if colleagues are happy to approve the recommendations in the report and the approach that Stuart and the team take? Yeah. Stuart, well done. Thank you very much. That's tremendous progress, and no doubt we will return to this fairly swiftly. Yeah. Thank you very much. Goes up. Right. Okay. moving on to item 9, the acute clinical services plan update. So the report from Linda for noting.
So yeah, just so you know, it's there, it's living. We're working hard on ACSP. Have to be prudent for obvious reasons that might just affect the timeline for our engagement, because we can't go out unless we've got the right materials and people to do it well. But we have got some resources, and we're doing what we can with those to really prepare us for getting ready for that next phase. But just wanted you to know that I don't want to be too quiet, because then you'll think nothing's happening, and that's not true. But I also want to flag that we are a little bit held back a little bit whilst we have to do the thing, but we all understand.
And you've gone out to recruitment, or going out to?
We did actually go and didn't appoint. We're having a different approach.
Right. Okay. The report is here for noting. Any questions to Linda? Okay. I'm sure we'll come back to this, Linda, in our September board meeting. Yeah. Okay. Thanks. Okay. Moving on to item 10, the consent agenda. Those matters for approval, items 10.1 down to 10.1.6. If I can ask just for approval of those items that are listed there in the consent agenda. Thank you very much.
Can I just mention to colleagues, just in case, not 10.2.66, the SPA policy for doctors, just to say that's a really important policy that we're approving, and there might be some noise on the back of it. So it's basically the allocation of extra time for doctors outside of their core clinical duties. We've got a variety of arrangements currently in play, and we're attempting to standardise that. But as you can imagine, where those have been in place for quite a long time, that I just wanted to flag to you that you're signing off something there that might generate quite a bit of noise, and you might pick up if you go on walkabouts or speak to any doctors there. They may raise some concerns, but
just on that, can I just check on my list? It's down for noting, not for approving. Does that require board approval?
Been approved at the
it's been approved at the executive. I don't think it needs.
I don't think it does.
Sorry, I think it's more just
for noting.
Yeah.
It's on my list
Yeah.
of notes as well
Yes.
to approve. So just to say the board is noting
Yes.
that on.
Yeah.
Noting. Yeah. Okay. Thank you, Paul. Okay, can I ask Paul then just to the minutes to note those items, the noting item 10.2.1 down to, as Paul said, item 10.2.6. There's no other business that I've been made aware of, unless anybody else has anything they need to raise this morning. Under item 11.2, if I can just ask colleagues to put forward any comments for improvement in terms of how the meetings are running, any reflections on today's board meeting. We can do that within the next 2 weeks. I would be very grateful. The next meeting of the public board is scheduled for Thursday, the 26th of September, and the annual general meeting will also be held on the same day. So that will take place after the board meeting on the 26th of September. Rydw i'n dod y gyfarfod o bodd iechyd ben. I'll bring the meeting to a close, and my thanks to all those who've contributed to today's board meeting. Thank you all very much.
Thank you. Well done.
Well done. Thank you very much.